filtered load, and it is equivalent to that of the GFR URE. Into the urea is the filtered load per day in a healthy individual, and urea is reabsorbed always by passive method. Now it is the GFR. You take 180 liter per day multiplied by the plasma urea in millimole per liter. You can find out the value. In a reliable text, there is given some data in milligram per deciliter of nitrogen, urea nitrogen. Urea is to 25 milligram per deciliter. And in the SI unit is given 2.8, 2.9 to 8.9 millimole per liter. এখন তোমাদের উপর দায়িত্ব দেওয়া থাকলো যে ইউরিয়া নাইট্রোজেনের যদি এই মান হয় তাহলে পরে এই মানটা মধ্যে তুমি এটা কি করে নির্ণয় করবে, বুঝতে পারছো? এইটা তোমাদের দায়িত্ব রইল। এটা আমি এক সপ্তাহ বাদে জিজ্ঞাসা করব যে এই যে ভ্যালুটা দেওয়া আছে একটা বিশ্বাসযোগ্য গ্রন্থ থেকে, রিলায়েবল টেক্সট, ইউরিয়া নাইট্রোজেন in serum 8 to 25 milligram per deciliter, that is equivalent to 2.9 to 8.9 millimole per liter, and it is your duty to convert this value, compare this value from this to convert to this. এটা আমি এখানে করব না, কারণ you are intelligent boys, and after 1 week I will pick up any of you and ask him to how it is possible. যদি না পারো কোনো গালাগালি দেওয়া হবে না, হ্যাঁ, বুঝতে পেরেছো? কোনো, কিন্তু আমি জিজ্ঞাসা করব যারা উপস্থিত আছো। Now urea is fully filtered. Now it is the filtered load per day, and it is absorbed only passively, but does not mean there are transporters. There are urea transporters, and it is substance that is filtered, reabsorbed, and ultimately and secreted to some extent, and there are urea transporters, UTA, and they are named UTA 1 to 4. 4 types of transporters, and another is UTB, that is in the RBCs. Erythrocytes, that is the UTB. Now here, that is the passive and facilitated diffusion, and when it is paracellular route, that is not required. It enters along with the water, solvent drag. But when through the cell, then some urea transporter is helpful. Otherwise, urea cannot easily enter into the cells. Clear? And it is reabsorbed passively, and it is secreted to some extent in the thin descending limb of loop of Henle and thin ascending limb of loop of Henle, but in the other part of the nephron, except the terminal part of the collecting duct, it is not reabsorbed. So it gets concentrated into the distal tubule, connecting tubule, collecting duct, cortical medullary, and in the papillary, only in the papillary collecting duct, especially in response to antidiuretic hormone, it comes into the interstitium, and where it helps to maintain the peritubular concentration. And in this way, when the urine is concentrated, you can expect that 50% of 1200 milliosmol per kg in the interstitium is due to urea. Yeah. And when the urine is dilute, and then ADH is not effective to a great extent. If we drink plenty of water, and then there is less secretion of antidiuretic hormone or vasopressin, and so this urea recirculation into the terminal part of the loop 2 terminal part is less, and so that the osmotic gradient is also reduced. And in this way, it is flow dependent. Urea reabsorption is flow dependent. When the urine concentration is more, or in other ways, when the flow is reduced, then urea is reabsorbed to a great extent, excretion is less. So its clearance is dependent upon the urine flow rate. And it is the behavior of a substance that is filtered and dealt by the kidneys. Now, of this filtered load, it is reabsorbed passively 60 millimole per. So excreted is this value. So excreted is that it is 410 millimole per day. So 53%, more than 50%, 53% is reabsorbed. 460 divided by 870 into 100. So 53% is reabsorbed. And urea is coming from the metabolism of protein metabolism. So whenever there is increased protein intake and the metabolism increases, and so urea is more available as in the filtrate and also in the interstitium. So medullary gradient is affected by this. So concentration of urine will be more with high protein diet. Urinary concentration depends upon this urea, and it depends upon protein diet. Yeah. And the clearance of urea and clearance of inulin, if you consider, a graph is given in some reliable rates. The urine flow rate, and it is the clearance. Suppose it is the case of inulin clearance. Per minute, it is equivalent to that of the GFR. That is 125 ml per minute. But in case of urea, it is flow dependent and it is fixed. It is independent of this flow rate. Bujha gelo? Inulin clearance is independent of flow rate. So its value is parallel to that of the abscissa or the urine flow rate. But in case of urea, it will be this type of figure. Urea. It is the characteristic of a substance that is filtered and that is dealt passively, only passively. That it depends upon the flow rate. Suppose in case of proximal tubule, if you consider, there is reabsorption of water, 2/3 is reabsorbed along with sodium chloride and other glucose and other important electrolytes. And so urine is concentrated to 1/3. So urea concentration initially that goes on increasing, and so its concentration it travels to the paracellular route and also to the cellular route by means of urea transporters. Further details you can find in big books. I can remember everything in detail. And it is of the role of urea in producing this peritabular concentration gradient. Now, water diuresis. It may appear as a short note. Water diuresis. If you drink plenty of water, it is your common experience that after some time there is increase in the urine flow rate, and there is a particular value beyond which it is not possible to drink that water. There is a maximum diuresis, and diuresis is due to the lack of action of antidiuretic hormone. Antidiuretic hormone acts upon the distal nephron, collecting tubule, collecting duct. Yeah. And in the absence of ADH, huge amount of water can be excreted in complete diabetes insipidus. And in that connection, we have to think what occurs in the different parts of the segments of the nephron. In the proximal tubule, or simply water that is reabsorbed, which percent of the filtered load of water is reabsorbed in the proximal tubule? তোমাদের জানা আছে কারু? আমরা কি বললাম 2/3 সেখানে অ্যাবজর্পশন হয়, মানে 65%. Normally 65% of the filtered load is loop of Henle's loop. Which part of the Henle's loop water is reabsorbed? Thin descending limb of loop of Henle. And here thin descending limb. 15% is reabsorbed. And in the distal tubule, convoluted tubule or simple distal tubule, it is absorbed as it is 5%. So the remaining part in the collecting duct, it will be 85% is reabsorbed. So at the beginning of the collecting duct 15% remaining. And even in the absence of ADH, 2% is reabsorbed. So minus ADH, 2% is reabsorbed. So urine 13%. 13% of filtered load in urine. 13%. And if it is 13% per day, it will become liter per day. Per day. তাহলে এটা হচ্ছে লিটার পার ডে, তাহলে 180 into 1000 into 13 by 100, 144 ml per minute. বুঝতে পারছি? তাহলে ইউরিন ফ্লো রেট এরকম দাঁড়াবে ml পার মিনিট। তাহলে এটা ওই মোবাইলে এটা ক্যালকুলেশন করে বলো তো কত ml পার মিনিট হয়, মোবাইলে ক্যালকুলেটর দিয়ে এটা বলো দেখি কত হয়। এটা 1440 মিনিটে আমাদের দিন হয়। হ্যাঁ, এই জন্য যদি ভাগ করতে হলো, আর লিটারকে ml এ পরিণত করতে 1000 দিয়ে গুণ করতে হলো, ml পার মিনিট কত হয় দেখো। হ্যাঁ, 4, আচ্ছা জোর কানে কানে কম শুনি আমি, 16.25। হ্যাঁ, 16.25 ml be produced, that can be produced 16 ml. It is the maximum value, but if you drink plenty of water, then it is sufficient to dilute it and ADH will disappear quickly. So after 15 minutes or so, there is increase in the urine flow rate for micturition, and it is peak level reaches 40 minutes or so, till the extra amount is eliminated. Or sense of fullness of bladder is 150 ml. It is the sense of fullness of bladder. Normally flow rate is approximately 1 ml per minute. So after 150 minutes you can have another second sense of micturition. বুঝতে পারিস? মানে যেই সময় মূত্র ত্যাগ করা হলো তার থেকে 150 মিনিট বাদে সেটা সম্ভব। 150 মিনিট মানে হচ্ছে 2.5 ঘন্টা, 120 মিনিটে 2.5 ঘন্টা। এই জন্য পরীক্ষার সিস্টেমটা হয় 3 ঘন্টার মধ্যে পরীক্ষা। কাজে 180 ml জমা হলে পরেও খুব বেশি সেরকম হওয়া উচিত না, সুস্থ লোকের অত বেশি হওয়া উচিত না, আর সেরকম আসবে না। এই জন্য এরকম 3 ঘন্টা পরীক্ষাটা ঠিক আছে। তারা যখন বাথরুম থেকে করে এসে যখন পরীক্ষা দিতে বসলো 3 ঘন্টার মধ্যে তাদের ওঠা উচিত নয়, কিন্তু তার আগেই অনেকে উঠতে থাকে। এত তো ডায়াবেটিক লোক নেই যে উঠতেই থাকবে। কাজেই যেটা যায় সেটা হচ্ছে বাথরুমে যায়, একটুখানি এদিক ওদিক কমিউনিকেশন এখন এটা আরও বেড়ে গেছে, বিজ্ঞানের এটা দান। তারপরে এবং যার ফলে ওগুলো বুঝেও চুপ করে থাকতে হয়, বুঝতে পেরেছেন? এর জন্য 1 ঘন্টা পরে থেকে বলছে স্যার একটু বাইরে যাচ্ছে, ওইটা এইরকমভাবে যেতে থাকে। আর সেখানে হল কালেকশন নানা রকম হতে থাকে। কাজেই এইরকম সবটা মিলিয়েই আমরা এটা পরীক্ষাটা পাওয়া যায়, এবং আমরা এগুলো জানলেও আমরা এগুলো কখনো কাউকে আটকাই না, বুঝতে পেরেছ? কিন্তু টাইমটা 3 ঘন্টা ওই জন্যই দেওয়া আছে, ঠিক আছে? কিন্তু আমরা চলে যাই। তাহলে এটা হচ্ছে তোমার, এটা হচ্ছে ডাইলুট ইউরিন যখন হবে তখন কিভাবে হবে, ম্যাক্সিমাম কত ফ্লো হতে পারে, দ্যাট ইজ দি 16 ml per minute, but it can be exceeded in case of osmotic diuresis. If you think in the other way, maximum capacity of dilution, suppose maximum capacity of concentration in an individual is 1200 milliosmol per kg, maximum capacity of urinary concentration, and minimum suppose it is 30 milliosmol per kg. And if the individual has the requirement to maintain its health or homeostasis, you have to liberate 600 milliosmol. It includes all the osmotically active particles, electrolyte, non-electrolytes, excreta, whatever it may be, and he have to eliminate this. So whenever this type of concentration is possible, then 600 divided by this kg or liter, whatever it may be. So half liter of urine is mandatory. If it goes below half liter, then some of the elements will accumulate. Nitrogenous substance will accumulate, uremia will take place. On the other hand, if you consider this milliosmol is the maximum value, then what should be the, so in that case 600 divided by 30 per day 20 liter of urine is to be produced, can be produced. বুঝা গেল? You can think it another way. Per day is to be produced. Per day. When it is maximum dilution, there is no ADH is active. Drinking profusely, and then maximum value is this per day. You can convert it into minute or ml. 20 into 1000 divided by 1440. So you will get a particular value close to this value. In this way, you can also think. Yeah. Now, the last part, in the third part is the water intoxication. Water intoxication. Water is essential for our existence. But if an individual is taking water voluntarily to exceed this value, so what will occur? Then there will be hypotonicity in the body fluid, including central nervous system. So water will imbibe into the cells, including the cells of the central nervous system. And if cortisol is deficient, there may be glucose fever, or simply there may be convulsions, coma, and rarely it may be cause death. If due to surgical trauma or so, there is increased ADH secretion that is not dependent upon the volume or osmolality, and water is not restricted, and in that case, this type of water intoxication can be there. There may be convulsion, coma, and maybe death. Yeah. And for this reason, water is restricted to some extent after prolonged surgeries. It is a theoretical basis. It is called water intoxication. And if it is coming as a short note, then you have to explain in this way. What is the maximum dilution possible? And in case of water diuresis, there is a fixed value. You can get a fixed value. It varies individual to individual according to its capacity to maximally dilute the fluid. Yeah. And this hypotonic fluid is produced. Hypotonic fluid is produced in diabetes insipidus. And in water diuresis, the water absorbed in the proximal part of the nephrons remains same. But the facultative part that is dealt in the distal nephron, that is affected, because it depends upon primarily the antidiuretic hormone and secondarily to the medullary interstitium, osmotic medullary interstitium. Yeah. Now we can deal with osmotic diuresis, and whenever there is osmotic diuresis, this value can be exceeded. Osmotic diuresis. Osmotic diuresis. Osmotic diuresis. If there is presence within the tubules osmotically active substances that are not reabsorbed, then they will have their effect, and they will hold water. Yeah, they will hold water. Suppose mannitol is infused in an individual. In some treatment of CNS, mannitol was introduced to reduce the cerebral edema produced due to the disease. Because it is not easy to decipher what is occurring within the brain. It may be hemorrhage, it may be thrombosis, it may be embolism, whatever it may be. And previously, it was almost a routine practice. When a cerebrovascular accident patient is admitted in the ward, then routinely this type of infusion was given, mannitol. But in those days, the standard of academic discussions was below par these days. They asked us to give this fluid, but why this fluid is given and what is osmotic diuresis, there is none to explain. বুঝতে পারছো? এজন্য তোমাদের নিজেদের শেখার প্রয়োজন আছে। কাজে আমরা যখন ছিলাম কতগুলো আমাদের ব্যাড ডেজ চলে গেছে, ডার্ক ডেজ চলে গেছে, কিছু অজ্ঞ লোক ওরকমই চিকিৎসা করতো। তারা চিকিৎসাটা ঠিকই করতো প্যাটার্নটা, কিন্তু তারা কারণটা অনেকে জানতো না। একটা স্টিরিওটাইপ চিকিৎসা করছে, যেটা ওরা জানতো ভিজিটিং, তাদের সময় ছিল না, ইচ্ছাও ছিল না যে যারা ছাত্র হিসাবে আসছে তাদের কিছু শেখানো উচিত যে কেন চিকিৎসাটা করা হচ্ছে, এটার যে বিজ্ঞানসম্মত ভিত্তি কী, এটার কারো কোনো সেরকম উন্নত রুচির লোকের আমি কখনো কন্ট্যাক্টে আসিনি। থাকতে পারে হয়তো বা, কিন্তু আমি কখনো আসিনি। হ্যাঁ, তারা শুধু নিয়মটা শুধু পালন করত। Now osmotic diuresis what occurs? In the renal tubule, if you consider, if there is mannitol or any other substance that is not reabsorbed and it is osmotically active particle and it will try to hold water, especially whenever there is water enters into the proximal convoluted tubule, there is some reabsorption of the sodium chloride, glucose and other amino acid substances, and water follows. And when this water becomes concentrated, then the concentration of these osmotically active particles which are non-reabsorbable, their concentration will increase and they will hold water. They will hold water. And in this way, within the proximal nephron, proximal tubule, the volume of water will increase. Sodium concentration is get reduced. And this, but the fluid is isoosmotic. Sodium concentration is low because of the presence of non-reabsorbable solutes. Concentration of, so in per unit time, the distal, that is the loop of Henle, is presented with a isotonic volume containing fluid, flow rate will increase. Sodium concentration is low, but per unit time more sodium is available, and at the same time sodium concentration is going down. So this difference of sodium that can be dealt by the reabsorptive mechanism is exceeded, so that no further sodium reabsorption is possible. Whenever there is active reabsorption from low concentration to high concentration, of course, but there is a limiting value beyond which it is not possible to further reabsorb. The pump can work for up to a limit, but when the sodium concentration is very low due to increase in volume owing to the presence of non-reabsorbable solute, then this limiting concentration is reached. So sodium is not reabsorbed. So in the thick ascending loop of Henle, where sodium is reabsorbed by sodium potassium 2 chloride ion transporter, that is also reduced. So medullary concentration gradient is reduced. Medullary, depending upon the presence of the osmotically active particles, non-reabsorbable, then there is the limiting concentration is reached, and sodium and other electrolytes are not reabsorbed. So the concentration gradient in the peritubular fluid or medullary interstitium is reduced. So huge amount of the fluid is entering in the distal nephron, and in the collecting tubule, even if vasopressin is present in high concentration, and it can operate only whenever there is concentration gradient, there is a gradient, but due to the reduction of this gradient, water is also not reabsorbed in the collecting tubule or collecting duct, and a huge amount of water can be eliminated, and its concentration can go on increasing up to the level of the plasma concentration, plasma osmolarity. Yeah. And for this reason, it is possible to concentrate the urine in case of diabetes insipidus patient by osmotic diuresis. And in the book you will find the pictures like this. It is 300 milliosmol per kg. It is isoosmotic. Isoosmotic, 300 milliosmol. To that of the extracellular fluid. And this abscissa, it is the osmolarity, and it is the flow rate. Suppose in case of diabetes insipidus, 12 liter per day if you consider. Normally its concentration is low, below 60 or so, and whenever this and it concentration will increase along with the flow rate. Suppose it is 21 liter per day. You will find this figure in clear and undistorted form. In this, it is for the understanding only. Suppose whenever it is 1400, maximum vasopressin is active, and when it is osmotically active particle is injected experimentally also, and it will reduce, and it will approach this asymptotically. It is the diabetes maximum vasopressin. So whenever osmotic diuresis is produced, huge amount of fluid can be produced, and the fluid is coming from the proximal part of the nephrons, so that in diabetes insipidus, suppose it is 12 liter per day, and initial concentration is 60 if you consider, and it will increase, because with osmotic diuresis, water is fluid is coming from the proximal part of the nephron, and proximal part of the nephron and very proximal part, that is within the Bowman space, that is equivalent to that of the plasma. So when the concentration will rise, then there is coming from the more proximal part, and it will try to approach these values, isoosmotic value of the plasma. Similarly, whenever there is maximal vasopressin in an individual, it is 1400 milliosmol per kg or liter, it is possible. But if there is osmotic diuresis, osmotically active particles are present in the urine is high concentration, and the ADH is failing to exert its effect gradually, because in the loop of Henle, sodium concentration goes to such a low level, limiting value, that further reabsorption is not possible. In the normal individual, within the proximal tubule, 2/3 of the fluid is reabsorbed, So inulin concentration will increase 3 times, but it remains isoosmotic. And whenever there is osmotic diuresis, it will remain isoosmotic, but the volume reabsorbed is reduced. Sodium concentration is going down, but for a particular unit time, this excretion is increased. And whenever there is very high amount of this osmotic, there is osmotically active particle is reduced, and the limiting concentration is being produced. Not only in the proximal tubule, but in the thick ascending limb of the loop of Henle, that is the distal tubule, limiting concentration of sodium is reached, in which further sodium reabsorption is not possible. So water is failing to get into the interstitium. So, and you all know that is the loop of Henle is the countercurrent multiplier. If sodium is failed to be reabsorbed, then how it is possible? Role of urea is a passive one. It is dependent upon that of the thick ascending limb of loop of Henle, active absorption. So medullary concentration gradient is reduced. So the urine concentration go on decreasing, because more fluid is coming from the proximal nephron and they are remain untouched due to decline in the medullary concentration gradient. The similar feature is seen in case of loop diuretics, furosemide, isacrinic acid. When they stop the reabsorption of at the thick ascending limb of furosemide, Lasix, you are familiar with. যাদের প্রেশার আছে, যাদের বাড়িতে হার্ট ফেলিউরের রোগী আছে, তারা ল্যাসিক্স নাম সম্বন্ধে সবই জানে। বুঝতে পারছো? Then the same thing occurs. As sodium is not being reabsorbed, then what occurs? Then medullary concentration gradient is reduced. And in that case, even if vasopressin is there, it is failing in their action, because its mechanism of action depends upon the water transport quickly through the aquaporins, in the collecting tubule or collecting duct. Water will move from the lumen into the interstitium, following the medullary gradient. And in this way, in a normal individual, when maximum concentration is this value. In other species, it may be higher. In case of dogs, it is 1800. In case of rats, it is 2400. And in desert rodents, it may be 5000 millismol. Such a concentration is possible. But whenever there is osmotic diuresis, then ADH has not its proper function. And so fluid is coming in huge amount, and in that case, it will approach this isosmotic value. That is the value of this extracellular fluid, asymptotically. বুঝতে পারছো? অ্যাসিম্পট কাছাকাছি যাবে কিন্তু কখনো মিলবে না। And flow rate, there is another figure close to it in your text, and where there is description in the other way. Here they consider this urea, that is the concentration of the osmotically particles in the urine, and the flow rate in the abscissa. And it is also the same value, same concept. And in that case, suppose quickly in the abscissa, in that case, it is the osmotically active particles in the urine per minute. It is go on increasing, and it is this urine flow rate. Per day, if you consider per day, and in that case, suppose it is this isosmotic, it is going to the origin, it is isosmotic. It is isosmotic. Whenever there is osmotically active load increases, it will increase. And how to, if to draw this figure, you have to consider the normal value. Normally, you can consider in a day 1 liter of urine is produced. 1 liter of urine is produced. If you have to figure 1 liter, and it is 600 active particles per day, it is eliminated. So per minute you can find out 1440 vertical particle. এটা হচ্ছে তোমার এটা 0.5 এরকম হবে, 0.5 এর কাছাকাছি হবে বা 0.4 ধরো, 0.4। তাহলে এখানে একটা ভ্যালু হয়ে যাবে, আর করেসপন্ড করছে এটা হচ্ছে 1 লিটার। It is isosmotic, and it is in this case consider 12 liter, and along with this it is volume, and it is almost parallel to this value, diabetes insipidus. And with maximum vasopressin, it will increase. Suppose such a low value, less than this, low value 0.5 liter, and this is it will increase, and after that it will and it will, you will have this type of figure in the text. বুঝা গেল? ছবিটা দেখে যখন একটু চিন্তা করবে তখনই বুঝতে পারবে কিন্তু কিছু কঠিন কিছু নেই। Whenever there is the milliosmol per minute, that is this in the urine, osmotically active particle is reduced because osmotic diuresis in being produced in that condition, in experimental animals or in the human beings if you consider. And in that case, then fluoride is due to absence of ADH, and then fluoride will go on increasing. It is almost parallel to that of this value. Clear? And in diabetes, in maximum ADH, initial volume is low, but with increase in the amount eliminated, and it will gradually become parallel to that of this isosmotic curve. This figure also try to explain this. এবং আমার যতটুকু জ্ঞান বুদ্ধি আছে আমি আলোচনা করে দিলাম, এবং তোমরা এগুলো বইগুলো দেখবে, দেখলেই তোমরা বুঝতে পারবে। বুঝতে পারছো? তোমরা আর থেকে আরো বেশি বুঝতে পারবে। কোনো যে জায়গায় ত্রুটি থাকলে সেটাও তোমরা নির্ণয় করতে পারবে, এবং সেটা নিয়ে আমাকে বলতেও পারবে যে আপনার এই জায়গাটায় এইটা ত্রুটি হয়েছে। তাহলে পরে হবে কি তোমার জ্ঞানটা বৃদ্ধি হবে। বুঝতে পেরেছো? নাও GFR and urine, glomerular filtration rate due to any reason, then there is the watery part that is present within the tubular lumen will be reduced. Suppose if there is dehydration is produced in an individual or in an animal, then GFR will be reduced. So whenever GFR is reduced, when water is coming to the loop of Henle, counter current multiplier, then the flow rate will decrease, and with decreasing flow rate, then there is more reabsorption of whatever amount of electrolyte that is present or urea that is available. So, the urine, that is this medullary concentration gradient will increased. At the same time, the flow rate is also reduced. So, highly concentrated urine can be produced. So, it depends upon the GFR. Due to low flow rate, if in an experimental animal, that is diabetes insipidus, you constrict renal artery on one side, and in that case, on the non-constricted side, the urine will be hypotonic, flow rate will be high, but on the other, on that side, that renal artery is constricted, and the GFR will be low due to presence of low pressure, and in that case, the urine concentration will increase in a diabetes individual patients. So, it depends upon the GFR also. Whenever the GFR is reduced due to dehydration or so, and in that case, the loop of Henle will get limited less amount of water to
so, to complete the deep cervical fossa, already you know, internal carotid artery, not the external carotid artery. এটা মনে রাখবে। And internal jugular vein and vagus nerve, and in the upper part also the 9th, 11th and 12th nerve. And this carotid sheath, when cut at the level of the, when you cut the neck at the level of the thyroid gland, it will be here. Internal carotid artery. So, already I have told you the pretracheal layer, of which only একটাই যেটা জানতে হবে, pretracheal layer makes a false capsule around the thyroid gland, of the thyroid gland. This is the thyroid gland. And makes a false capsule. And this, as the pretracheal layer attached to the hyoid bone above and the thyroid cartilage, and also a posterior layer of this thyroid capsule, pretracheal layer, attached to the cricoid cartilage, this is known as the ligament of Berry. So, in this way, thyroid gland via this layer attached to the hyoid bone, thyroid cartilage and cricoid cartilage. Cricoid cartilage by which medium? The ligament of Berry. So, when we swallow or deglutate to take water, it is a rule that hyoid bone the thyroid cartilage and the cricoid, means larynx, moves up and down with deglutition or with swallowing. So, as we deglutate or swallow, thyroid gland also moves up and down with swallowing, as these are attached to these bones and cartilage through this medium. And there are so many midline structures present. For example, a lymph node may be enlarged here. A dermoid cyst, a skin tumor containing fluid, a sebaceous cyst may be present here, and a thyroid swelling also be present here. So, in the bedside, how do you differentiate? We ask the patient to swallow, to deglute, or give a sip of water. If the swelling moves and up and down with deglutition, it is derived from the thyroid gland, either a goiter, thyroid swelling, or thyroglossal cyst, a embryological tumor of the thyroid gland. But this lymph node will not move; it will remain as it is. So, this is the importance of the pretracheal layer. Next, clinical. So, next layer is the prevertebral. And it extends from the base of the skull, and lower extent is very important, ostium pore. একটু বুঝতে হবে, and posteriorly you look, it is through the ligamentum nuchae, কালকে বলেছি, through the ligamentum nuchae, খুব ভালো কথা. Anteriorly, right side of the prevertebral with the left side. Now it has been told that this condensation of the deep fossa around this artery, vein and vagus nerve, mainly. This carotid sheath has got a posterior layer, is derived from the pretracheal layer, and posterior layer of the carotid sheath is derived from the prevertebral layer. So, carotid sheath formation is contributed both by the pretracheal layer and the prevertebral layer. Anterior wall of the carotid sheath is formed by the pretracheal layer, and posterior wall of the carotid sheath is formed by the prevertebral layer. So, prevertebral layer, যেটা আমি এঁকেছি, this is the carotid sheath. Anterior layer is formed by the pretracheal layer, prevertebral layer. This is the carotid sheath. This is the prevertebral layer, right? এরপরে দেখো, most important, এটা হচ্ছে next picture is more important. This picture খুব ভালো করে দেখো এটা. This is the cut section করেছি. সুতরাং প্রথমে আছে ইনভেস্টিং and pretracheal, তারপরে এটা হচ্ছে prevertebral. কেমন? ও আরেকটা পড়তে হবে, এটা বলার আগে একটু, না হলে বুঝতে পারবে না, আছে কিনা দেখি. আচ্ছা, এখানে পরে দেখাবো, এখন দেরি হয়ে যাবে, কোথায় আছে খেয়াল পড়ছে না. আচ্ছা, তার আগে একটুখানি বলি, ফ্যারিংস, না হলে এটা বুঝতে পারবে. ফ্যারিংস আমরা জানি ইসোফেগাস এখান থেকে শুরু হয়েছে, তার উপরে জাস্ট অ্যাবাভ ইসোফেগাস, when we take food we go to the mouth cavity, and the mouth cavity, the food now goes to the pharynx. কোথায় যাচ্ছে? Pharynx-এ. And pharynx in the lower down is continuous with the esophagus. Esophagus then continuous with the stomach and so on. So pharynx is a part of the gastrointestinal system partly, because pharynx is a peculiar viscera which has got a dual role both in airway as well as the food tube, pipe or food tube. So pharynx is a peculiar things, right? দরকার নেই, আমরা ফুডটাতে থাকি, GI tracted, it is a upward beginning of the GI tract. গেল, খুব ভালো কথা. What is the layer of the GI tract? Esophagus, stomach, etc. Inner mucous membrane, then submucous, then muscularis externa, then adventitious layer. We know that rules. In the pharynx also these norms are maintained. Inner mucous membrane, lining epithelium, followed by submucosa, followed by muscularis externa, followed by serosa or adventitia. Serosa or adventitia. Serosa or adventitia. Pharynx, there are some peculiarity. Mucous membrane, let mucous. But the submucosa is specially thickened and derived from the deep fossa, and it is called pharyngobacillar fossa. আমরা এখানে সাবমিউকোসা বলি না, কি বলি? pharyngobacillar fossa. Pharyngobacillar fossa. Which is also derived from the deep fossa. And muscularis externa has, in the pharynx, has a peculiar arrangements. There are some longitudinal muscles and some circular muscle. These circular muscles are arranged in three separate muscles. These are called constrictor of the pharynx: superior constrictor, middle constrictor and inferior constrictor. তিনটে মাসল কনস্ট্রিক্ট করছে, আর সার্কুলার মাসল ইজ অ্যারেঞ্জড ইনসাইড দিস কনস্ট্রিক্টর ইন লঞ্জিটিউডিনাল ডাইরেকশন, রাইট? তাহলে কি কি কনস্ট্রিক্টর, লঞ্জিটিউডিনাল মাসল এখন ভুলে যাও, কি কি কনস্ট্রিক্টর রয়েছে? ওপরে সুপিরিয়র কনস্ট্রিক্টর, সুপিরিয়র কনস্ট্রিক্টর ধরো এই রকম সুপিরিয়র কনস্ট্রিক্টর, তারকে এরমভাবে রয়েছে মিডিল কনস্ট্রিক্টর, তার তলে রয়েছে ইনফিরিয়র কনস্ট্রিক্টর, ওভারল্যাপিং ওয়ান অ্যানাদার। মিডিলটা এটাকে সুপিরিয়রকে ওভারল্যাপ করছে যাতে কিছু বেরিয়ে না যেতে পারে, অ্যান্ড ইনফিরিয়রটা overlap করছে, but there are certain gaps in between them, and through this gap certain important structures goes inside the pharynx. সেটা পরে আসবো, কেমন? আচ্ছা, ছেড়ে দাও, এটা গেল। তাহলে কি কি কনস্ট্রিক্টর রয়েছে? সুপিরিয়র, মিডিল অ্যান্ড ইনফিরিয়র কনস্ট্রিক্টর, মোর অর লেস ইন দ্য সেম প্লেন, জাস্ট ওভারল্যাপিং ওয়ান অ্যানাদার, আউটসাইড রয়েছে। আর ভেতরে লঞ্জিটিউডিনাল মাসলসগুলি রয়েছে, স্টাইলোফ্যারেঞ্জিয়াস, ক্লসোফ্যারেঞ্জিয়াস এটসেট্রা, salpingopharyngeus, palatopharyngeus, etc. ছেড়ে দাও। নেক্সট, this outside layer, adventitia, is also specially thickened and also derived from the deep fossa and form a covering of the pharynx, outer covering of the pharynx, one on all sides, and this is called, very important, pharyngeal fossa. বাক্যোফ্যারেঞ্জিয়াল ফসা। এটা যদি ফ্যারিংস হয়, দিস violet color is the baccopharyngeal fossa. As a adventitia, tunica adventitia is covering the outer wall of the pharynx. It is a cut section. Actually, baccopharyngeal fossa covering the pharynx in this fashion. বুঝতে পেরেছো কি? কাট সেকশনটা এরকম লাগছে, কিন্তু অ্যাকচুয়ালি ইট ইজ লাইক দ্যাট, লাইক এ টিউব কভারিং দ্য ফ্যারিংস। সো আমরা যদি পরপর আসি, ফ্যারিংস, বাক্যোফ্যারেঞ্জিয়াল ফসা, দেন প্রিভার্টিবল ফসা, রাইট? এবং এই স্পেসটার নাম রয়েছে, দেয়ার ইজ এন স্পেস, ডেড স্পেস, রেট্রোফ্যারেঞ্জিয়াল স্পেস। Retro means back, so this space we call retropharyngeal space. Very important, retropharyngeal space. কেন রেট্রো? রেট্রো কেন বলছে? রেট্রো মিউজিক মানে কি? এই যে হোয়াটসঅ্যাপে দেয় রেট্রো মিউজিক, হ্যাঁ, পেছনের দিকের 80s, 70s, 1960 মিউজিককে বলা হয় রেট্রো মিউজিক। 1960, 1970 মিউজিক, 1980, 1990 মিউজিককে আমরা বলি রেট্রো মিউজিক। কেন? পেছন। Similarly, this space is backside of the pharynx, so this is known as the retropharyngeal space. And this space, lateral between এই স্পেসটাকে বলা হয় lateral pharyngeal space, আসবো আমি পরে। সো retropharyngeal space is very important. এরপরে আমি তাহলে এটা রয়েছে, তাহলে আমি যদি এই ছবিটা দেখি, এই যে এরপর যদি কাট সেকশন দেখছি, ইনভেস্টিং লেয়ার, স্প্লিটস টু এনক্লোজ এ স্পেস, suprasternal space ছেড়ে দাও। This is the pretracheal layer attached to the hyoid bone, thyroid cartilage, cricoid cartilage, and splits to enclose the thyroid gland, thyroid gland, and attached to the lower down pretracheal layer, attached to the fibrous pericardium. এটা খেয়াল রাখবে, lower down pretracheal layer, above it is attached to the hyoid bone, then to the thyroid cartilage and cricoid cartilage, comes down, and pretracheal layer attached to the fibrous pericardium. It is the baccopharyngeal fossa. ... Right? খুব ভালো করে দেখো, it is the baccopharyngeal fossa. পেছনে এইটা হচ্ছে pharynx, তারপর esophagus হবে, and backside of the baccopharyngeal fossa, it is the prevertebral fossa. Prevertebral fossa, and it is the vertebra. So this space, এই স্পেসটা, এটাকে বলা হয় retropharyngeal space. Retropharyngeal space. So back to prevertebral fossa. Prevertebral fossa, above it is attached to the, দেখো কোথায় লাগছে, base of the skull. পরে যখন পড়বে এই জায়গাটাকে ক্লিভাস বলে, ওইখানে এসে লাগছে, স্ফেনয়েড এবং অ্যাক্সিপিটাল বোনের আন্ডার সারফেসে লাগছে। অ্যাভাব তাহলে এটা অ্যাটাচ করছে কোথায়? বেস অফ দ্য স্কান, অ্যান্ড লোয়ার ডাউন একটা পিকুলিয়ার ঘটে, এবং ইট ইজ ইম্পর্টেন্ট ক্লিনিক্যালি, তার জন্য আমি স্ট্রেস দিচ্ছি। এই অ্যাট দ্য লেভেল অফ দিস হিয়ার আপারে, দিস প্রিভার্টিবল লেয়ার ইজ এ সিঙ্গেল লেয়ার। খুব ভালো করে শোনো প্লিজ, মাথা থেকে সব ঘুরিয়ে দাও। আপার Atlas, HC, C1, C2, it is a C3, it is a single layer. যেই আরেকটু নিচে নেমছে, this prevertebral layer splits to form two layers. One anterior layer, one posterior layer. এটা খুব ভালো করে শোনো, one anterior layer, one posterior layer. Anterior layerটার নাম অনেক সময় আমরা বলি alar fossa. Alar fossa. So এইখানে যদি এটা যদি বাক্যোফ্যারেঞ্জিয়াল ফসা হয়, সামনে ফ্যারিংস রয়েছে, এটা ফ্যারিংস, এটা হচ্ছে বাক্যোফ্যারেঞ্জিয়াল ফসা। এইটা হচ্ছে প্রি ভার্টিব্রাল ফসা, এইটা হচ্ছে রেট্রোফ্যারেঞ্জিয়াল স্পেস, বড় করে গেছে, দেয়ার ইজ এ নো সাচ লার্জ স্পেস, প্রায় বোঝাই যায় না। And lower down it splits to form alar fascia and এটা হচ্ছে বাক্যোফ্যারেঞ্জিয়াল fascia অরিজিনাল, এই প্রিভার্টিব্রাল fascia posterior layer, alar fascia না বলে anterior layer বলতে পারি। This anterior layer ultimately attached to the বাক্যোফ্যারেঞ্জিয়াল fascia in lower, এই জায়গাটা এসে and prevertebral fascia টা যেটা posterior layer of the prevertebral fascia is ultimately attached to the anterior longitudinal ligament and the periosteum of the T4 vertebra, which means at the sternal angle ultimately posterior layer is attached. কেন ইম্পর্টেন্ট আসছি আমি, এইটা লোয়ার এসে এখানে অ্যাটাচ করে গেল। এরপরে আরেকটা জিনিস তোমাদের বুঝতে হবে, না হলে ক্লিনিক্যাল অ্যানাটমি অথবা নেক্সটে সত্যি যদি তোমরা ইএনটি সার্জন হও বুঝতে অসুবিধা হবে, আমি এক্সপ্লেন করতে পারবে না, বুঝতে অসুবিধা, ইউ ক্যানট এক্সপ্লেন। ছিলাম হ্যাঁ আছে, তাহলে এইটা যদি রেখে দিয়ে গেছিলাম প্রিভার্টিব্রাল লেয়ার, এইটা বাক্যোফ্যারেঞ্জিয়াল অ্যান্টিরিয়ারলি, আমার ক্ষেত্রে বলছি ইট ইজ দ্য অ্যান্টিরিয়ার সাইড, বা তোমাদের ক্ষেত্রে এটা হচ্ছে বাক্যোফ্যারেঞ্জিয়াল ফাসা, এটা হচ্ছে প্রিভার্টিব্রাল ফাসা। কেমন? দিস স্প্লিটস টু টু টু, এখানে দুটো হয়েছে আর নেই, যে জায়গায় এটা আছে, এইটা ভালো করে বুঝবে। অ্যান্ড ইট দিস প্রিভার্টিব্রাল লেয়ার splits to form two layer, anterior, এই সাইড দিয়ে দেখাই, anteriorly alar, posterior layer of the prevertebral fossa. These alar fossa ultimately attach to the prevertebral fossa in lower down, right? গেল? এছাড়াও আরেকটা কাণ্ড ঘটে, and that is the important key. এই অ্যালার ফাসা থেকে অ্যান্টিরিয়রলি একটা সেপ্টাম যায়, দিস ইজ দ্য অ্যালার ফাসা অ্যান্টিরিয়র লেয়ার, ভালো করে বোঝো, ইট ইজ অ্যান অ্যালার ফাসা অ্যান্টিরিয়র লেয়ার আলটিমেটলি অ্যাটাচ টু দ্য বাক্যোফ্যারেঞ্জিয়াল ফাসা। নট অনলি দ্যাট, এই অ্যালার ফাসা থেকে at the level of the pharynx, a midline partition goes and attached to the baccopharyngeal fossa, dividing this space into right half and a left half. বুঝতে পেরেছো? এই মিড লাইনে অ্যালার ফাসাটা এইভাবে অ্যাটাচড হয়ে গেল, মিড লাইনে, সাইডে কিন্তু খোলা, তাহলে এরকম দেখতে লাগছে। সো দিস রেট্রোফ্যারেঞ্জিয়াল স্পেস is now divided into right half and a left half, and it is not, right half is not continuous with the other. এইটা হচ্ছে ফ্যারিংস। এরপরে ধরো যদি এখানে সোয়েলিং হয়, there is a gland present here and swelling, তাহলে কি মিড লাইনে সোয়েলিং হবে না একটা সাইডে হবে? ভালো করে বোঝো, this space is divided into two half. If there is a swelling here, তাহলে ফ্যারিংসটাকে পুশ করে এটা মিড লাইনে থাকবে না একটা সাইডে থাকবে? হ্যাঁ, ভালো করে বলো, বোঝো। আমি এখানটায় ছবিটা আঁকি তাহলে বুঝতে পারবে। এটা ফ্যারিংস, এইটাই ধরো ফ্যারিংস, এটা রেট্রোফ্যারেঞ্জিয়াল স্পেস, এইখানে হচ্ছে পার্টিশন, this is the baccopharyngeal fossa, it is the prevertebral fossa, and midline it is attached here, dividing this retropharyngeal space into right half and a left half. বুঝতে পেরেছো? এই যে মিডলাইনে যেটা অ্যাটাচ করেছে, so if there is an swelling here, it will swell, swelling will be, we push this pharynx in this fashion, তাহলে এটা কি মিড লাইনে হলো না একটা সাইডে হলো? হ্যাঁ, ওয়ান সাইড। আমরা এটাকে বলি প্যারামিডিয়ান। কি বলি? প্যারামিডিয়ান। এরপরে ধরো এইখানে ভার্টিব্রা রয়েছে, ভার্টিব্রা ইজ এফেক্টেড বাই টিউবারকুলোসিস, তাকে কি বলি? কেরি স্পাইন। when the vertebra is affected by infection occurs in the vertebra, whatever the vertebral level, cervical, thoracic, lumbar, আমরা বলি কেরি স্পাইন। কেরি স্পাইন, tuberculosis of the vertebra. So pus is formed here, and pus is formed here. Ultimately, it pushes this pus become enlarged, fashion. তো এটা কি মিডলাইন হবে না? যেহেতু পেছন দিকে চাপ দিচ্ছে। সো যদি রেট্রোফ্যারেঞ্জিয়াল স্পেসে হয়, anterior to the prevertebral fossa, any pus formation, it will be paramedian. আর যদি any pus formed behind the prevertebral layer, this is the prevertebral layer, it will be in the midline swelling. That is important. আমরা একবার শুধু এখানে একটা এন্ডোস্কোপ দিয়েই ধরে নেব, it is behind the any infection is behind the prevertebral or in front of prevertebral layer. যেই বলে নেব তখন আমরা ইটিওলজিও জেনে নেব যে যেহেতু midline swelling, it is posterior to the prevertebral, so possibly origin is from the vertebra. আর যদি প্যারামিডিয়ান সোয়েলিং হয় তাহলে আমরা পসিবল অরিজিন ইজ দ্য retropharyngeal space, and the possible cause is the lymph node, কারণ retropharyngeal space এ only lymph node and few pharyngeal vessels আর loose irregular tissue ছাড়া কিচ্ছু থাকে না। তাহলে whether the swelling is in the paramedian position or midline, through which we can make a provisional diagnosis whether it is a anterior to the prevertebral fossa or infection of the retropharyngeal space, or posterior to the prevertebral fossa, or the infection derived from the vertebra. তাহলে এইটা আমরা ইজিলি বুঝতে পারি, একদম বেড সাইডে, কোনো স্ক্যান ফ্যান লাগবে না। তবে টুডে দিস মেথডস আর গ্র্যাজুয়ালি রিপ্লেসড বাই দ্য ডেভেলপমেন্ট অফ দ্য সিটি স্ক্যান, একদম ডেফিনিট জেনে যায়। আচ্ছা যাকে, তাহলে আরেকটা তোমরা এবার ইন্টারেস্টিং বলো, ইফ দেয়ার ইজ অ্যান কেরি স্পাইন হিয়ার, আচ্ছা আরেকটা জাস্ট একটা বলে নিই। সো প্রিভার্টিব্রাল ফসা কি হলো এখন? কি হ্যাঁ, বাইরে গেছিলে মানে ছিলে, তাহলে বলে যাবে তো। আচ্ছা আরেকটা যেটা বলি, এই যে প্রিভার্টিব্রাল ফসা বললাম, the brachial plexus পড়েছো, it has got a root, trunk, division, cord. Root and trunk is present in the lower part of the neck. While these trunks are coming to the axilla behind the clavicle, it draws টেনে নেয় a sleeve of the prevertebral fossa, and the name which forms a covering around the trunks of the brachial plexus. Number 2, খুব ভালো করে শোনো, axillary artery. Sorry, axillary কি বলছি, এই subclavian artery, but not the vein. Subclavian artery and axillary artery, but not the vein, not the vein. তাহলে কি হলো, এই যখন এখান দিয়ে roots of brachial plexus জানছে, যাচ্ছে, it draws a strip of fossa covering this, এবং this স্লিপটার নাম হচ্ছে অ্যাক্সিলারি শীথ। এই যে আমরা অ্যাক্সিলারি শীথ বলি, ইট ইজ ডিরাইভড ফ্রম দ্য প্রিভার্টিব্রাল লেয়ার অফ দ্য ডিপ সার্ভাইকাল ফাসা। অ্যান্ড অ্যাক্সিলারি শীথের কন্টেন্ট হচ্ছে, ভালো করে শোনো, অ্যাক্সিলারি আর্টারি and the trunks of the brachial, axillary subclavian artery and axillary artery and trunks and cords of the brachial plexus, but not the axillary vein. কেন নয়? কমন সেন্স কি বলে? কেন অ্যাক্সিলারি ভেন ঢোকায়নি? আরো তো কভারিং হতো। শীথ ইজ গিভেন টু গিভ দ্য প্রোটেকশন। কেন নয়? বিকজ এইখানে ফিমোরাল ভেনটা তোমরা লক্ষ্য করো, সব সময় আমরা ফিমোরাল ভেনে ফিমোরাল ক্যানেল থাকে কেন? গিভ এ ডেড স্পেস। ভেন অলওয়েজ ডাইলেটেড। যখন ভেনাস রিটার্ন হয়, ভেন গেটস ডাইলেটেড, স্পেস মাস্ট বি দেয়ার টু অ্যাকোমোডেট দ্য ডাইলেটেড। যদি অ্যাক্সিলারি শীথ ইজ এ টাইট কভারিং, মোজাটা ভীষণ টাইট, সেখানে যদি ভেন ঢুকিয়ে দাও, ভেন ডাইলেট করতে পারবে না। সুতরাং ভেন ইজ নট ইনক্লুডেড উইদিন দিস অ্যাক্সিলারি শীথ। তাহলে সেইটা গেল। আচ্ছা, এরপরে বলো, খুব ইন্টারেস্টিং, বুঝে পড়লে, ইফ দেয়ার ইজ এন ইনফেকশন অর ক্যারি স্পাইন হিয়ার, এই স্পাইন পাস ইজ গ্র্যাজুয়ালি অ্যাকুমুলেটিং অ্যান্ড ইট ইজ এ টেন্ডেন্সি টু স্প্রেড। স্পার্ট মানে হচ্ছে অলমোস্ট লিকুইড লাইক স্ট্রাকচার or caseous like structure, it has tendency to spread, যেখানে ডাউনওয়ার্ডস পাবে, রাস্তা পাবে, চলে যাবে। কোন কোন জায়গায় যেতে পারে? সামনে কোথায় কম্প্রেস করবে? টুয়ার্ডস দ্য ফ্যারিংস। অ্যান্টেরিয়রলি কম্প্রেস দ্য ফ্যারিংস অ্যান্ড ফর্ম এ মিডিয়ান সোয়েলিং। নিচে কত দূর যেতে পারে? শুধু এইখানটা জেনে রাখো, এটা T4 এ গিয়ে এটা লেগে গেছে, তাহলে নিচে কত দূর যেতে পারে? এইখানে একটা ইনফেকশন হলো, কত দূর নামতে পারে? হ্যাঁ, আপ টু, এরপরে যেতে পারবে কি? পারবে না। সো it will extend up to the lower border of the T4, means superior mediastinum অবধি যেতে পারবে। সুতরাং any infection in the neck may go to the thorax up to superior mediastinum. Any infection of the neck নয়, any infection of the vertebra, carry spine for example, behind the prevertebral face, it can go down. Pretracheal layer infection হলো, এইখানটায় ওটা কত দূর যেতে পারে? আপ টু মিডিল মেডিয়াস্টিনাম। বুঝতে পেরেছো? এই যে এখান দিয়ে নেমে আসছে, ফাইব্রাস পেরিকার্ডিয়াম কোথায় থাকছে? মিডিল মেডিয়াস্টিনামে, মেডিয়াস্টিনামে যেতে পারছে। সুতরাং এইগুলি সো ইট ইজ ইম্পর্টেন্ট। সো হাউ লং দ্য স্প্রেড, আর কোথায় যেতে পারে? একটা হিন্ট দিয়েছিলাম, এক্সিলারি শীথ। থ্রু দ্য এক্সিলারি শীথ it can go up to axilla. So infection is here, C3 spine, pass is here. কেন গেল এখানে? কোথা দিয়ে গেল? Through the axillary sheath. Axillary sheath এর মধ্য দিয়ে চলে গেল। এই যে এখান দিয়ে এই পেরিফেরাল লেয়ারের একটা এখান দিয়ে আপ টু দ্য অ্যাক্সিলা। সুতরাং কোশ্চেন যদি থাকে, অ্যাক্সিলা যেতে পারে অ্যান্ড সুপিরিয়র মেডিয়াস্টিনাম অবধি যেতে পারে আপ টু T4 ভার্টিব্রা। সো আজকে না এগুলি এই যে এটা হচ্ছে রেট্রোফ্যারেঞ্জিয়াল স্পেস ডিভাইডেড বাই এ মিডলাইন সেপ্টাম অ্যান্ড রেট্রোফ্যারেঞ্জিয়াল স্পেসের কন্টেন্ট হচ্ছে এরপরে একটা তোমাদের কম্পিটেন্সিতে আছে স্পেসেস অ্যারাউন্ড দ্য ফ্যারিংস দেয়ার আর টু স্পেসেস one is the retropharyngeal space another is the lateral pharyngeal space retropharyngeal space আগেই বলেছি it is behind the buccopharyngeal fossa it is the buccopharyngeal it is the anterior side it is the posterior side and the prevertebral fossa and this space is divided by a midline septum into right and left half the contents is the retropharyngeal lymph node pharyngeal few branches of the pharyngeal vessels and nerve and loose areolar tissue any infection of this retropharyngeal space এইটা শুধু মনে রাখো causing প্যারামিডিয়ান সোয়েলিং এই প্যারামিডিয়ানটা মনে রাখবে বোঝো আর না বোঝো প্যারামিডিয়ান সোয়েলিং any infection behind the prevertebral fossa causing midline swelling এই যে দেখেছো এটা হচ্ছে মিডলাইন সোয়েলিং আমরা এন্ডোস্কোপি দিয়ে দেখছি হিউজ প্যারামিডিয়ান সোয়েলিং একটা সাইডে সোয়েলিংটা হয়েছে এই যে রেট্রোফ্যারেঞ্জিয়াল অ্যাবসেস ইন এক্স-রে পুশিং দ্য pharynx anteriorly next হচ্ছে lateral pharyngeal space it is a space just lateral side of the pharynx which is bounded তোমাদের এখন বুঝতে অসুবিধা হবে anteriorly by the medial pterygoid muscle posteriorly by the parotid gland এখন আমি জাস্ট বলে দিচ্ছি একটুখানি এখন বুঝতে পারবে না আর medially by the pharynx and posteriorly by the carotid sheath just এই জায়গাটায় submandibular region এটা কেন পড়ছি it is very close to tooth and mouth and sometimes at a minor tooth infection খুব ভালো করে শোনো এটা একটা টার্ম বলবো মনে রাখবে it is an emergency medical emergency surgical emergency any tooth infection especially in the molar tooth পেছনের দিকে যেটা রয়েছে may spread to the lateral pharyngeal space causing abscess in the lateral pharyngeal space and these abscess may spread to the undersurface of the tongue and pushing the tongue upwards and compresses the larynx causing airway obstruction and difficulty in breathing and this is known as the এইটা তুমি জেনে নাও এটা 3 ডাইমেনশনাল বিউটিফুল পিকচার আছে এইটা হচ্ছে মাউথ ক্যাভিটি এটা হচ্ছে টনসিল একটুখানি নিজেরা এটা বোঝবার দরকার নেই বেশি অ্যানাটমি অ্যান্ট্রিয়ালি রয়েছে মিডিয়াল টেরিগয়েড মাসল এইখানটায় এবং পেছন দিকে রয়েছে এই প্যারোটিড গ্ল্যান্ড পেছনে রয়েছে ক্যারোটিড শীথ আর এদিকে রয়েছে ফ্যারিংস তার মধ্যে রয়েছে টনসিল এই স্পেসটাকেই বলা হচ্ছে এখানে হাত দিলে টনসিলের বাইরে যে হাত দেবে সেইটাই হচ্ছে ল্যাটারাল ফ্যারেঞ্জিয়াল স্পেস দিস ল্যাটারাল ফ্যারেঞ্জিয়াল স্পেস যদি ইনফেকশন হয় it may spread to the under surface of the floor of the mouth under surface of the tongue pushing the tongue upwards and also is swelling in the cheek and causing obstruction to difficulty in respiration এত কম্প্রেস করে দেয় এখানে ট্র্যাকিয়া ল্যারিংসকে বলে ইট ইজ এ মেডিকেল এমার্জেন্সি এবং কন্ডিশনটার নাম হচ্ছে লাডউইগস অ্যাঞ্জিনা। হয়ে গেল লাডউইগস অ্যাঞ্জিনা। এটাকে কি বলে? cellulitis by abscess formation in the floor of the mouth, pushing the tongue upwards and compressing the airway, causing difficulty in breathing, and it is called Ludwig's angina. It is an emergency. Within minutes তোমাকে অ্যাকশন নিতে হবে, আইদার ড্রেন করতে হবে, ইন্ট্রাভেনাস ফ্লুইড দিতে হবে, অক্সিজেন দিতে হবে, and if necessary ট্র্যাকিওস্টমি করতে হবে, otherwise patient may die. তো সিম্পল টুথ ইনফেকশন একটা টনসিলাইটিস থেকে এই সিরিয়াসনেস হতে পারে। সুতরাং ইউ হ্যাভ টু ইয়োর মাইন্ড যে পেশেন্টকে একটা সিম্পল টনসিলাইটিসকে পেশেন্ট বা পেশেন্টের গার্জিয়ানকে ইউ হ্যাভ টু অ্যাডভাইস ইফ দেয়ার ইজ এ সাচ অ্যান্ড সাচ সিমটম ইমিডিয়েটলি রিপোর্ট টু মি অর গো টু দ্য এমার্জেন্সি। এবং সুতরাং ইটস এ ভেরি পেইনফুল কন্ডিশন, সো ইট ইজ কল্ড লাডউইগস অ্যাঞ্জিনা। ইজ এ ইনফেকশন ইন দ্য রেট্রোফ্যারেঞ্জিয়াল স্পেস, mainly from the tonsil infection or tooth infection, molar tooth infection. এটা মনে থাকে যেন। এটা যদিও রেয়ার, আজকালকার যুগে এত গুড অ্যান্টিবায়োটিক বেরিয়ে গেছে এখন আর দেখা যায় না, আগে দেখা যেত। আচ্ছা, ক মিনিট আছে? একটু আছে। আচ্ছা, নেক্সট আমাদের তাহলে ডিপ সার্ভাইকাল ফসা থেকে কি কি কোশ্চেন হতে পারে? Why thyroid gland moves up and down with respiration? Number 2 হচ্ছে রেট্রোফ্যারেঞ্জিয়াল স্পেস, শর্ট নোট, ক্যারোটিড শীথ, শর্ট নোট, carotid sheath, short note, spread of the infection behind the pretracheal layer, behind the prevertebral layer, in the retropharyngeal space. কোথায় কোথায় যেতে পারে, নিচে অ্যাক্সিলাতে, এগুলি সব পড়তে হবে। I have already told you triangles of the neck. There are anterior triangle and a posterior triangle. Which is the divided muscle? Sternocleidomastoid. Sternocleidomastoid, as a short note, I have told you details. Origin, insertion, nerve supply. Applied একটা দিতে ভুলে গেছি, সেটার জন্য আমি বলছি। স্প্যাজমোডিক টর্টিকোলিস অর রাইনেক, এটা কমন নেম হচ্ছে রাইনেক। ডিউ টু ডিফিকাল্ট বার্থ, বেবি বর্ন করছে, শোল্ডার প্রেজেন্টেশন, প্রথমে যখন বার্থ হচ্ছে, দিস নেক বিকাম স্ট্রেচড, মানে বেরোচ্ছে না, টানছে, হ্যাঁ, যে অ্যাসিস্ট্যান্ট গাইনোকোলজি অবস্টেট্রিশিয়ান টানছে, ফলে নেক মে বি স্ট্রেচ, ফরসেপ দিয়ে টানছে, নেক মে বি স্ট্রেচ, সো দেয়ার মে বি ড্যামেজ টু দ্য ব্রেকিয়াল প্লেক্সাস, causing Klumpke's paralysis, causing Arp's palsy or Klumpke's paralysis. Plus, এইখানে কি হয়, there is a bleeding within the sternocleidomastoid. এই যে টান হচ্ছে, মাসলটা স্ট্রেচ হয়েছে, ক্যাপিলারি উইদিন দ্য মাসল বিকাম সিভিয়ার, ছিঁড়ে গেছে, and there is a bleeding within the sternocleidomastoid muscle. Baby is born and it is healed by fibrosis. Whenever fibrosis, there is a contracture. যখনই মনে থাকবে ফাইব্রোসিস যখনই হবে, কন্ট্রাকচার হবে। অ্যাজ এ রেজাল্ট, suppose this side sternocleidomastoid is damaged, there is a fibrosis and contracture and neck is like that. অনেক রাস্তায় দেখবে এরকম করে যাচ্ছে। This is the example of spasmodic torticollis or wry neck. There are other causes also, congenital cause and other tumor and other causes also. One of the common cause is the difficult delivery and stretching of the neck during delivery. তাকে কি বলে? স্প্যাজমোডিক টর্টিকোলিস অর রাই নেক। এটাও তোমাদের কম্পিটেন্সিতে আছে বলে আমি বলে দিলাম। বারবার বলছি, you need no suggestion, you just go the competency. You can 100% you can answer. No question will come to the outside the competency level. AN 41, 42, 43 যেগুলি আছে উনি প্রত্যেকটা দেখবে কম্পিটেন্সি। নেক্সট হচ্ছে আমরা জানি there are two muscles, sternocleidomastoid and trapezius. We divide the triangle into an anterior triangle and a posterior triangle. What is the boundary of the anterior triangle? Lower border of the mandible up to the symphysis menti to the angle, and then an imaginary line from the angle to the mastoid process. So this is the upper boundary. The anterior boundary is the midline of the neck, and posterior boundary is the anterior border of the sternocleidomastoid. So this is the anterior triangle, and posterior triangle is that anteriorly posterior border of the sternocleidomastoid, lower is the clavicle, middle third of the clavicle, and posteriorly the anterior border of the trapezius. So this is the posterior triangle, this is the anterior triangle. This is the posterior triangle, and this is the anterior triangle, right? And for the, so anterior triangle is a large area. So to have a more specific, we divide the anterior triangle into number of divisions. By two muscles, digastric muscle and omohyoid muscle. Digastric muscle has got an anterior belly and a posterior belly, and omohyoid muscle has a superior belly and a inferior belly, and omohyoid muscle passes behind the posterior to the sternocleidomastoid, so part we cannot see here. So anterior triangle and posterior, anterior triangle is divided by number of subdivision into number of small triangles. Which, what are the muscles which divide? Digastric anterior belly and a posterior belly of digastric, superior belly of omohyoid, mainly superior belly, inferior belly is meant for the posterior triangle. সুতরাং এইটা হচ্ছে anterior triangle. So sub কি হচ্ছে? এটা হচ্ছে বলা হয় digastric triangle or submandibular triangle. Very important. This is the carotid triangle, and here is the muscular triangle, and this is the submental triangle. And submental triangle, actually in one side it is the half triangle. So when we meet the two triangle together, it is a full triangle. So submental triangle, actually in one side of the neck it is a half triangle. So we call that the anterior triangle of the neck of each side has got 3.5 triangle. 3.5 triangle. 3 kiki, carotid triangle, digastric triangle, muscular triangle. Half triangle ta ki ei jagata submental triangle. Our posterior triangle is divided by posterior belly of the digastric into occipital triangle and supraclavicular triangle. Ashbo amra. So this is the anterior triangle. of the neck. সুতরাং তোমাদের ডিসেকশন যখন হবে, আমি তো ডিটেলস এখানে পড়াবো না কারণ ইট উইল বি ডিসেকশন, বাট আমরা কালকে যেটা পড়াবো ইম্পর্টেন্ট আর্টারিজ, ভেসেলস, এগুলি যেগুলি কাজে লাগবে সেগুলি আমরা পড়বো, তাহলে ইট উইল বি হেল্প ইন ইউর ডিসেকশন অ্যান্ড অলসো দ্য শর্ট নোটস, ট্রাই টু মেক ইট দ্য শর্ট নোটস.
The spinal cord or extension of the brain or brainstem runs through along with the covering. We call them as vertebral canal. Now then we have this particular third element, we call them as process. That means it is directed towards different directions. So the process, if it is directed laterally, we call them as lateral process. If it is directed on the back side, we call them as spinous process. Now to join this particular process with this vertebra, we need some bridging bones. We call them as lamina or pedicel. So if you see this particular block element, which is the vertebral body, and this particular lateral extensions coming through it, we call them as the transverse process, which is running transversely. And then we have another process projected on the side, which is lying on the back side. We call them as dorsal process or the spinous process. So we call them as SP and TP, transverse process. Now to join this body with this particular process, we have this particular element, we call them as lamina. So these are the basic elements, and along with that lamina, this particular body with this particular lamina is joined by a tissue, we call them as pedicel. So this is in general parts of this particular vertebra. So we have this particular vertebral body, we have a canal which is present through it, we have the spinal cord running through here, and this particular thing has process, laterally extending, we call them as transverse process. If it is back side projected, we call them as spinous process, which is most posterior part, and vertebral body, which is most anterior part. So this is a general part. Now this particular cervical vertebra also have got this particular part. So to classify the cervical vertebra, we can divide this. The vertebrae which looks alike, we call them as typical, and which do not look alike, we call them as atypical. So out of this typical, which is similar looking, 3, 4, 5, 6 and 7 can be called as typical because they look similar, and the atypical is kind of the vertebrae which do not look similar. We call them as atypical cervical vertebra. That means they have some feature which not matching with the rest of the vertebrae. Now this counts this together 1, 2, 3, 4, 5, 6, 7 as this particular vertebra is there. Now whenever you are seeing this vertebra, you have to classify whether it belongs to this particular cervical region, or it belongs to this thoracic region, or it becomes the lumbar region. So each of these particular vertebra have got features. So let's talk about the vertebral feature of this particular cervical region is that, so start with the body. So this particular body of the cervical vertebra is thin, and it's not that like not enough bony material is there compared to this particular lumbar or compared with this particular spinal region. So body is small, and this particular body, if you just like look at them, it's likely looks like a small heart shaped structure. So this is a body which is the cervical vertebra has, and this is way less than that of this vertebra which is in the dorsal segment or this thoracic segment, with this one which is lying in the lumbar segment. So you can see this comparative difference between this, the body girth, length, everything together. It's way too small compared to the lumbar. So body is too small and it's thin as well. And these particular bodies may have some kind of like a projections, like a little bit like a carved upside as well. So this is kind of like a feature which is not there in the bodies of these lumbar vertebra, which is like a disc shaped, flat, and it looks like a kidney shaped, it's like a kidney shaped structure, which is compared to this one is a heart shaped body, which is this cervical region has. Now next we have this particular canal. This particular canal we call them as the vertebral canal. So this is holding over there, this canal, spinal cord runs through it. Now this particular canal, which is vertebral canal, which is shaping over this particular cervical region is the canal looks like a triangular. So, this cavity, if you see this, it is a roughly triangular shaped cavity which is having a wider caliber there. So, if you look at this particular caliber or this girth of this particular canal in the lumbar region with the cervical region, you can see that cervical region cavity of this particular vertebral canal is more than that of lumbar region, and this particular thing which is present in here is a triangular shaped structure which is present in the cervical region. Now, next feature which helps us to identify is the process. Now, out of this process we have the spinous process. In this particular cervical region, the spinous process, tip of them may be bifid like this. So, the spinous process we call them as bifid spinal process may be present, especially the 7th cervical vertebra. And the transverse process which is transversely present in this particular region, it has a hole which is only present in this cervical region. So, this hole which is present in the transverse process we call them as foramen transversorium. So, which you have to keep in mind. Now, to summarize everything which helps us to identify this particular cervical vertebra is that it has a small thin body, it has a triangular cavity of the vertebral canal which is wide compared to the body, and this particular spine or spinous process is bifid, we call them as bifid spinous process, which may be seen in the thoracic region as well, but this bifid spinous process is very obvious in the 7th cervical vertebra. And this transverse process which is transversely present holds a hole inside to it, we call them as foramen transversorium. So, this transverse process is only here, we see a hole in here. The transverse process in the rest of this particular vertebra, we do not see any holes in it. So, in a glimpse or in a kind of like a far distance, this particular transverse process element or foramen transversorium is the key element to identify this bone as cervical vertebra. So, no other vertebras have this transverse process, have these holes. So, if you have a vertebra and if you see a transverse process which is pierced by a hole, that means this belongs to cervical vertebra. Cervical vertebra only transverse process holds this, rest of this transverse process don't have any holes in it. So, it could be anything but not cervical. So, if you have this particular hole in this particular transverse process, that makes this particular vertebra belongs to this particular cervical group of vertebra. And then you can just like figure out how the body looks like, how the canal looks like, how the spine which is bifid, how it looks like. So, this is how this particular vertebra is looked for or looked into. So, this is a hallmark to identify this vertebra. Apart from this, it has some facets. So, all these features which is present, body, canal, process, spinous and the transverse, along with that it has some facets, F-A-S-C-E-T-S. Now, this facets is for articulation of the other vertebrae. There are two kinds of facets is there, superior and inferior. Now, why these facets are there? Now, we see this vertebra is stacked one after another in a vertical directions. So, as this particular vertebra are stacked one after another, intervened by this particular intervertebral disc in between, this particular vertebra makes a joint with this particular bones above and below. So, when this particular vertebral parts which comes in contact with this particular parts of these bones, they make a joints. So, this particular joints makes an impression on that particular bones. We call them as facets. So, there are two such facets are there. One is for the articulation with the bone above and with the bone below. So, there are two articular facets are there, which is largely we see there present in the lamina. So, we see this particular lamina. So, this is spine which is joining with the body, we call them as lamina, which is joining over there. This part we call them as lamina. So in the lamina, if you see that in the end of the lamina, there are two projections are there, like hand-like projections, one hands up and one hands down. So this hands up and hands down bony piece, we call them as facets. So this hands up, hands down positions are there for articulating with the bones above and below. So we call them as facets. And the joints which are made over here, we call them as facets joints, which is a kind of synovial joint. So this particular articular process, we call them as superior facets and inferior facets, and they are articulating. So that we call them as superior articular facets and inferior articular facets. Every piece of bones of the vertebra have them. One above facet, one below facet. This one as well, lumbar one also have that. Superior and inferior articular facets. So this articular facets is to join with the bones which is above and below. Superior and inferior articular facets, we call them as facets joints, which is a synovial joints. These are the two joints which is synovial joints. And this particular joint between the bodies which are intervened by the cartilage, we call them as secondary cartilaginous joint. Because this particular joint joined by the fibrocartilage disc, we call them as IV disc, intervertebral disc. IV disc have got two parts, central part, nucleus pulposus, which is notochord element, and surrounding that we have a ring, annular fibrosus, which is surrounding to it, which is a fibro disc. So this IV disc, which is notochord element as well as sclerotome element, forms this particular bones. Now, to summarize everything, we have a vertebra. Vertebra have got few features. One is body. Then we have this particular canal process, which is articulating with the different parts. One facets or projections is there on the back side, we call them a spinous process or spine of the vertebra. One is transversely directed, we call them as transverse process. Now the spine joins with this particular transverse process with this particular piece of the bone, we call them as lamina. So lamina is that piece of bone, right side, left side, these are the lamina, which is joining with the spinous process with the lamina. And then with this particular body, with this particular articular facets, in between them we have a tiny bridge of tissue, we call them as, so this foramen transversarium is present only in the transverse process, okay. So that part we call them as pedicel. So the part which is joining with this part, we call them as pedicel. So with this particular transverse process and this body, we have pedicel there, and this part we call them as, these two we call them as lamina. So it's been already been covered in two separate classes already. So you have to have a very clear idea of what do you mean by the lamina, what do you mean by the pedicel, what do you mean by the transverse process, what do you mean by the spinous process, what do you mean by the body, what do you mean by the articular facets, what is superficial articular facet, what is inferior articular facets. So these are the basic elements of any bones, and what is a vertebral canal and what runs through this particular vertebral canal or vertebral foramen. Now having said that, this particular bone is a vertebral bone, and this particular vertebral bone we are saying this belongs to the cervical domain. How do you know cervical domain? We'll look into the transverse process. So this transverse process is pretty short or small. This transverse process, you see that this is projected, spinous one. This one as well projected on the side. This one is pretty small in the cervical region, and this small transverse process have got holes in there. That particular hole we call them as foramen transversarium, which is only present in the cervical domain. Now then we look at this particular spine. The spine looks like bifid. That means it's not single, it looks like two, half split. We call them as bifid spine, which is present in the cervical region. And then this particular body, which is thin, small compared to the rest part, and this lumen which is holding this particular lamina to it, we call them as vertebral canal, vertebral foramen, which is wider compared to the lumbar segment, compared to this particular rest of this particular vertebra, which is quite wide. So this makes this particular vertebra falls in the group of the cervical region. Lumbar region, no transverse foramen have got there. So this is belonging to either lumbar or cervical. So how do you know this particular, whether it belong to this particular cervical or lumbar? Sorry, cervical or thoracic region. The thoracic region have got facets for the ribs, which this particular bodies don't have. So we call them as costal facets. So costal facets is for the ribs attachment. Two costal facets are there again, above and below, for the articulating of same and the same below number ribs, which is lying in the sides of the body. So costal facets, which is present only in the thoracic region. Lumbar region don't have costal facets, don't have this transverse foramen. So that falls into a huge chunk of this particular body, which is having a diameter which is like a transverse diameter more than anteroposterior diameter, which is roughly kidney shaped, and the foramen which is holding in here, the vertebral foramen, which is narrow, small compared to the rest of this. And articular facets, every vertebra have got superior and inferior articular facets. So this is in general feature about the general vertebrae. Now we are talking about the vertebrae for this class is typical vertebra. That means we are talking about third, fourth, fifth, sixth, seventh. These are the vertebrae. Now, talking about the vertebrae attachments. So, largely we focus on the general features of the vertebra, but in case we have to talk about this particular some attachments of this vertebra. So, whenever you are given with this vertebra bone, you have to prepare this particular vertebra in two headings. There are two such attachments in the vertebra there. One is the intervertebral disc, and detail about the intervertebral disc you have to prepare. So, you have to know about IV disc, the embryology of IV disc, how it is formed, and the morphology of the disc, IV disc. Second thing is that the vertebra have got two things to attach. One is ligaments. So, you have to know the names of the ligaments which are attached to it. Second thing which is related to it is the muscles. The muscles is the last thing to prepare. So, you have to prepare this particular ligament. Now, there are two such ligaments are there which is present in the vertebra throughout the length. We call them as a longitudinal ligament. Now, there are two longitudinal ligaments are there. One is anterior longitudinal and posterior longitudinal. Now, what do you mean the longitudinal ligament? That means it runs throughout the length of this particular vertebral column. So, this is the vertebral column, though synthetic. So, it runs with this particular longitudinal. That means it runs from this particular part and ends to this particular lower part. So, then we call them as longitudinal ligament. Now, we call them as anterior longitudinal ligament and posterior longitudinal ligament. Now, how you classify anterior and posterior longitudinal ligament? Now, you see that this is particular vertebral body and this is spine. So, if a ligament is present on the anterior aspect of the body, we call them as anterior longitudinal ligament. And if this particular ligament is present on this particular posterior side of the body, we call them as posterior longitudinal ligament. So, there are two longitudinal ligaments are there. One is running on this side. This is the back side. So, it is running on this side where I am placing this particular canal. So, within this canal, if it is there, this is the posterior side, posterior longitudinal ligament, where I placed my index finger within this particular cavity. Now, anterior longitudinal ligament is present in here, in front of the vertebral bodies. So, where I place this marker. So, if this longitudinal ligament is present throughout the length, we call them as longitudinal. There are anterior longitudinal, which is this particular pen which I am marking related to this particular vertebral body. This is anterior longitudinal ligament. This is where this anterior longitudinal ligament is placed. The posterior longitudinal ligament, where I have placed this finger, this particular foramen, we call them as vertebral canal. So, this vertebral canal where this particular vertebral body is there, if this particular ligament is placed in here, we call them as this ligament as posterior longitudinal ligaments. So, this particular ligaments, we call them as longitudinal ligaments because they are running in the length of the vertebrae, anterior to the body, posterior to the body. Second set of ligaments, we call them as ligamentum flavum. This is pretty important. Now, this particular ligamentum flavum is a ligament which is present between this particular lamina of vertebra. Then we have to know what is lamina. So, this is lamina of the vertebra. So, if between the laminas, above, below, they are there, so then we call them as ligamentum flavum. So, they are present on the back side towards the spine side between this particular lamina. So, you have to identify the lamina of this particular bone, where this particular lamina is there, and they are running on this between the laminas. So, if it is tracked about this articular facets like this, ligamentum flavum are present in here between this lamina like this, right side, left side clustered together. নে এখানে ধর, ধরে ল্যামিনাটা এরকম করে দু হাতে ধর, হ্যাঁ, দিয়ে ল্যামিনাটা এই দুটো বোন ফিক্স করে রাখ একটার সাথে আরেকটা। So between the lamina, this particular ligament is there, which is known as ligamentum flavum. This is made of yellow elastins. That's why it's called ligamentum flavum. It looks like yellow. So this flavum is for this particular yellow tinge which this particular ligament has. So these are the three ligaments, anterior and posterior longitudinal and the ligamentum flavum. Then we have few ligaments to consider over here. We call them as interspinous ligament, which is number 4. That means between the spines, which is on the lateral side of the spines, we have a ligament. We call them as interspinous ligament. And number 5, we have supraspinous ligament. Supraspinous ligament is attached on the tips of the spine. So this is the spines of a vertebra. So if a ligament anchored to this tip of the spine, where I am touching, this is the tip of the spine. So if it is touching on the tip of the spine, we call them as supraspinous, which is tip of the spine. And in between the spines, above, below, if it is there, we call them as interspinous ligament. So these are the 5 sets of the ligaments that you have to know, with emphasizing on ligamentum flavum. Now taking to this particular supraspinous ligament. Now this particular supraspinous ligament in the neck region becomes very thick, and we call them as ligamentum nuchae. Or nuchae. It's a French word. So supraspinous ligament in the cervical region, which is touching the spines of the vertebra, is little bit thickened or little bit modified. We call them as ligamentum nuchae or nuchae. So this particular ligamentum nuchae or nuchae is a kind of element of this supraspinous ligament, which is little bit modified in the cervical region. That's what we have these names. Now you can forget about ligament nuchae because we do not have any anatomical landmark for it. But this longitudinal ligamentum flavum and interspinous, supraspinous, these basic ligaments is present all over the vertebral column. So these 5 ligaments are there in each and every segment of the spinal cord. So we have, vertebra. So we have to remember them. Regard to the ligament is done. Then we have these muscles. Now there is a one muscle I would ask you to remember in the neck region related to this particular vertebra. Is known as rectus capitis. Rectus means straight, capitis means head. This particular muscles, which is rectus capitis, is related to the skull bone. So that's why we call them as rectus capitis. It is a straight muscle which is anchored to this vertebra. Now this rectus capitis have got 3 brothers. We call them as anterior, posterior and lateral. So the lateral, posterior, lateral, anterior, posterior and lateral rectus capitis, they are present on 3 different directions of this particular back side of the spinal cord, back side of this particular vertebra. If it is lying on this particular posterior side, which is spinous end, we call them as rectus capitis posterior. If it is present on the transverse vertebra side, transverse process side, we call them as rectus capitis lateralis or lateral rectus capitis. If it is present on this particular front side of this particular body of this vertebra, we call them as anterior rectus capitis. Apart from that, there are several other muscles are there, splenius capitis, levator scapulae, etc., etc. They are there, but you won't be able to memorize them because hardly matters for us. But this muscle is easy to memorize, rectus capitis, and it has 3 brothers, good, bad, ugly. So that's what this particular vertebra is. So to summarize, it has body small, it has a foramen which is big, vertebral foramen, and it has process, transverse process, foramen which is present to it, and then it has a spinous process which is bifid, and it has lamina, it has pedicels which is related to this part. Now this particular bone have got facets to articulate above and below vertebrae, and this particular thing has a disc which is present in here, just any other intervertebral disc it has. It has ligaments, 5 of them, longitudinal, anterior, posterior. Then we have ligamentum flavum, which is yellow structure, elastic tissues are there, spinous, inter and supra. So these are the 5 ligaments which is present. Muscle 1, rectus capitis, good, bad, ugly, 3 brothers. That's it. Now little bit about the detail of this particular thing, which is the exam important question. Now we find this particular foramen. This particular foramen, we call them as in the transverse process as foramen transversarium. Now we have how many vertebrae? 7 vertebrae. So 1 to 6 and 1 to 7. Now what passes through this particular foramen is your exam question. So between 1 to 7, this particular foramen transversarium, that means number 7, number 6, number 5, 4, 3, 2, 1, all of them, foramen is traveling through it is vertebral vein. What passes through it? 1 to 7, vertebral vein. Between 1 to 6 is vertebral vein plus vertebral artery. So between 6, 5, 4, 3, 2, 1, we have vertebral vessels. Between 1 to 7 is vertebral vein. So the vertebral artery is not passing through which foramen? So these are the questions we are going to ask you. Question number 1. Now apart from these particular vertebral vessels, so we have this particular vertebral artery. So suppose this is vertebral artery which is passing through the foramen. Now climbing through the vertebral artery, what I am saying? Climbing to the vertebral artery, a nerve runs through. The nerve which runs through this vertebral artery, spiraling to it, we call them as sympathetic nerves. In the cervical region, it's a sympathetic nerve. There are 2 autonomic nerves are there, sympathetic and parasympathetic. The sympathetic nerves wraps around like this particular ferning pattern. This tiny skinny nerve wraps around this particular artery and runs through it. So as this particular artery runs through this particular vertebral foramen or foramen transversarium, this sympathetic nerve also runs through. So again to re-modify or recheck this particular foramen transmitting what? So, foramen transversarium, which is transmitting between 1 to 6 is vertebral vein, vertebral artery plus sympathetic nerve, SYN nerve. This is your exam question. We are going to ask you this particular question and mark the number. What this number is? 0. Person will get an answer, right answer for it. Now, between 1 to 7, the foramen, what wants to? Vertebral vein is constant all throughout, right? So, it is running through, but not the sympathetic. So, sympathetic one along with the vertebral vein enters to V6, C6. So, if it is a C6, we have C7 and C5 like this. So, we have this vertebral artery enters through here bypassing this C7, and only C7 is transmitted by veins, and the spiraling to this particular artery is the sympathetic nerve runs through. This is one exam question, or 3, 4, 5, 6, whatever questions we can go from this particular point. This is one. Now, there is another point about this particular cervical vertebra. This is the last part. We have the foramen transversarium, then we have this particular facets, so this is spinous process, which is like this. This is the lamina, and this part I am blacking with the ink is the pedicel, and this is transverse process. So, this is how this particular vertebra looks like in the cervical domain. Now, you see that this particular region where I am blacking with the ink, that means in the top of the pedicel, the spinal nerve exits through this part like this. So, spinal nerve, that means spinal nerve which is exiting through this particular region. So, which is C1, C2, C3 spinal nerves which is exiting through this particular on top of the pedicel and exiting out. So, this particular spinal nerve is exiting on, resting over the pedicel and exiting out from the lateral intervertebral foramen. So, lateral vertebral foramen, so you have to identify what is lateral vertebral foramen and how to see that. This is your task. Find a vertebral column, try to find out what do you mean by the lateral vertebral foramen and what passes through lateral vertebral foramen, which I already have mentioned. But you have to see yourself, see and identify this lateral vertebral foramen and what passes through this. Passes through this is the spinal nerves, but you have to see this particular lateral vertebral foramen, how does these things look like. So, this is about the typical cervical vertebra, general feature, gross features and special features, includes this particular identification, includes this particular ligament attachments, includes this particular joint which is formed by, there are two types of joint which is formed by each of the vertebra. One is the secondary cartilaginous joint, other is synovial joint. Synovial joint is present between these facets, and between this particular vertebral bodies we have the secondary cartilaginous bodies. What is the difference between the synovial joint with this particular cartilaginous joints, etc., that you have to know. And this particular element about this particular foramen, what runs through it, what is the clinical significance of this particular thing running through here, and lateral vertebral foramen, and where do this particular spinal thoracic nerve exit from or exit on. These are the other point of asking questions. So, you cannot come to the examination without knowing the cervical vertebra and this particular foramen on the transverse process, we call them as foramen transversarium. So, altogether we have 13 vertebral piece and these are the 4 pieces. Together we have 17 vertebral piece of the bone that is been distributed. Along with that, we have this particular synthetic vertebral column. So check yourself, and when you return, make sure you count it normal.
The thing you could get over here, so write it down. On the it is also known as norma basalis. Norma basalis, that means when you are seeing the skull from the inferior aspect. When you are seeing the skull from the inferior aspect. So that is also known as norma basalis. Okay. So if you see, you have to remember it is always without mandible. Norma basalis e kintu mandible thakbe na. Okay, it is always. Last bench, please do not make any noise. Okay, norma basalis is always without the mandible. This is the most complicated part I am telling you. Okay, so first one is anteriorly. How you could see? This is the teeth. So tell me the formula for the adult teeth. 2, 1, 2, 3. That means incisor is 2, then 1 for canine, then 2 for premolar, then 3 for molar. So what about the deciduous teeth? 20 number. Very good. And when does it means having it is taking out from the cavity? So it will start at the age of 6. Okay, and approximately within 10 years it will complete. বোঝা গেল 10 বছরের পরে যে টিথটা আমাদের থাকে সেটা হচ্ছে অ্যাডাল্ট টিথ ওকে সো ইউ আর taking this teeth, so that is known as incisor teeth. Okay, and this foramen is also known as incisive foramen. This fossa on the maxilla, this is also known as incisive fossa. So it will start anterior boundary, write it down, anteriorly by incisor teeth, anteriorly by incisor teeth, posteriorly by superior nuchal line. Now yesterday only I told you superior nuchal line. Tell me, superior nuchal line কোনটা বলেছিলাম? What is this? External occipital protuberance. From that lateral this margin, this is the superior nuchal line. Okay, so posterior margin is superior nuchal line. Then next one, laterally the rest of teeth. Laterally if you see the rest of teeth, so one by one we are coming. So laterally first one is the rest of teeth. Then there would be zygomatic arch. Which one is zygomatic arch? This one. So how does it will form? Frontal process of frontal bone. বোঝা গেল? Zygomatic arch. So next one is, if you see posterior root of zygoma. So what is zygoma? Do you know what is zygoma? This one. Okay, this is also known as posterior root of zygoma. This where the zygomatic arch finished. Okay, that point is known as zygoma. So this is the posterior root of zygoma. Then the last one is the mastoid process. Okay, last one would be mastoid process. কোন বোনের part? Mastoid process টা কোন বোনের? Temporal বোনের part. Okay. So if you see laterally rest of teeth, zygomatic arch, posterior root of zygoma, and last one is the mastoid process. Clear? So this is the boundary. So next, if you see the subdivision, so it is divided into, write it down, it is divided into anterior, middle and posterior. It is divided into anterior, middle and the posterior. Okay, hard palate and alveolar arch included in the anterior part. Now see over here, which is the soft palate and which is the hard palate. Do you know? Our oral cavity, which one would be in front? Hard palate. So this is the hard palate. Okay, the above the roof of the oral cavity. Okay, and posteriorly there would be soft palate. Okay, তার মানে আমি যদি টোটাল প্যালেটটাকে ভাগ করি, কতটা হার্ড প্যালেট কতটা সফট প্যালেট, কতটা হবে বল? 3/4 and 1/4. বোঝা গেল? 3/4 হবে তোর হার্ড প্যালেট, 1/4 হবে সফট প্যালেট. So এখানে থাকবে alveolar arch. Now tell me what is alveolar arch? This is the maxilla. So alveolar arch of maxilla. You write alveolar arch of maxilla. এই আর্চটাকেই বলছে alveolar arch. Okay. No, up to here. This is the whole is known as alveolar arch. Okay. So alveolar arch included and the hard palate. So an imaginary horizontal line. So if you see this line, Okay, so one imaginary horizontal line passing through the anterior margin of foramen magnum, and it separates the posterior from the middle part. From middle part and posterior part there is no separation. We are just drawing one imaginary line, just like mediastinum. ঠিক আছে, সত্যি কি এক্সিস্টেন্স আছে মিডিয়াস্টিনামে? না, we are thinking. So you are separating middle part from the posterior part by a imaginary horizontal line where it is passing in front of foramen magnum. You could find it out in front of foramen magnum, anterior margin of foramen magnum. So write it down the boundary. So an imaginary horizontal line passing through in front of foramen magnum, which is separating the middle part from the posterior part. Okay, now see over here, this is the picture. Okay, so you could see which one is the anterior part, only the hard palate and this alveolar arch. Okay, then next one is middle part. So if you see the middle part, which part are there? If you tell the middle part, so tell me which bone would be there? Anteriorly ki bone ache bol, pink color jeta seta ki bone? Palatine bone. Then if you go this side, both side, that is the zygomatic. Okay, then if you go this green color, see, this is also the palatine bone. You are wrong, the pink color is the maxilla. Okay, remember, front is the maxilla. এটা কিন্তু পুরোটাই maxilla. Okay, both left side and right side. তারপরে যেটা horizontal bone সেটা হচ্ছে palatine. Okay, so there would be zygomatic, and then see there is a sphenoid. So which one is the sphenoid? This is the sphenoid. Okay, so sphenoid has got greater wing and lesser wing. Lesser wing টা কোথায় থাকবে? Superiorly. Okay, আর greater wing টা inferiorly. ঠিক আছে, আর body থাকবে in body of the sphenoid. Okay, না, হার্ড প্যালেটটা তো তোর পুরোপুরি ম্যাক্সিলা দিয়ে ফর্ম হচ্ছে। ওকে, তারপরে যে অংশটা একটু সফটলি এক্সটেন্ড করছে, দ্যাট ইজ দ্য সফট প্যালেট। ওকে, এন্ড ইউ নো সফট প্যালেট ইজ ভেরি মাচ ইম্পর্টেন্ট, রাইট? ওয়াই? সো দেয়ার আর টু ডোর দ্যাট শাটস ডিউরিং ইউর, একটা হচ্ছে সফট প্যালেট আর একটা হচ্ছে এপিগ্লটিস। ওকে, সফট প্যালেট কখন কাজ করে? Suppose you are eating anything, right? It could go to the nasopharynx. যেতে পারে। Who is preventing? Soft palate. Okay. Now if you are eating something, that to also go to the larynx. Lungs এ যেতে পারে। কে করে? Epiglottis. বোঝা গেছে? So these are preventing this action. Okay. Then next one is, see, temporal bone. So temporal bone is actually making the middle part. Okay. And occipital bone is completely, it is making the posterior part because foramen magnum. Okay, it is situated in the occipital bone. ঠিক আছে? Now see, one by one foramen we will discuss. Okay, প্রথমে দেখ, see over here, first foramen you will found in the incisive fossa, that is known as incisive foramen. Write it down. First foramen is incisive foramen. Okay. Now see over here in the hard palate, you will see there are two lines that are going. One is vertical, another one is horizontal. Jeta vertical, that is known as intramaxillary suture. Write it down. Two maxilla is united together, so that is known as in between. Okay, intramaxillary suture. Okay. And if you see over here, the joint between the maxilla and the palatine, so that is known as maxillopalatine suture. Maxillopalatine suture. So you could also, horizontal হচ্ছে maxillopalatine suture, আর verticalটা হচ্ছে intramaxillary suture. So isn't it making one cruciform shape? Cross করছে কিনা? Okay. You could see over here, this suture is crossing together. So this is known as cruciform suture. Okay, cruciform suture. So if you go more laterally, what are the thing you could see? In the palatine, in maxillopalatine suture, if you see inferiorly, So you could find there are two foramen, greater palatine foramen and lesser palatine foramen. Now the question is which thing is passing over there? Incisive foramen দিয়ে কি যাবে? Do you know incisive foramen দিয়ে কি যেতে পারে? Incisive foramen দিয়ে কি যেতে পারে? So there are some branches of maxillary nerve. Okay, branches of maxillary nerve. Then next one is the greater and lesser palatine foramina. Now tell me, which thing will pass? Write it down. Greater palatine artery and nasopalatine nerve. মনে থাকবে একটা হচ্ছে greater palatine artery and the nasopalatine nerve. Okay. And if you see the superior aspect or roof of the oral cavity, you see the hard palate you touch over there, you could find there are numerous glands. These are known as palatine glands. Okay, write it down. These are known as palatine glands. Heart shaped gland আছে কি না? Hard palate. So that is the palatine glands. Okay. So next one is, if you go more laterally, what are the thing you could see? What is this? This is the zygomatic bone. Zygomatic arch. So you are getting the zygomatic arch. You have to remember each and every point. Okay, because it is very much important for your viva. Head neck viva holo sokale ei note ta must. Okay, so this is the zygomatic arch. Then next one is the vomer. So see, yesterday I am saying vomer. So which one is the vomer? This one. This is only unpaired nasal bone. Okay, so it will articulate with, দেখ কার সাথে articulate করছে? So it will articulate with the কার সাথে attached করছে? Palatine bone এর সাথে. Okay. Then the next one is the foramen oval. Now we are coming to the middle cranial fossa. Okay, anterior cranial fossa is over. Now coming to the middle cranial fossa, which is very much complicated. Okay. So first thing, what you will see, এটা কি বলতো? You could see the opening. What is this? This is the posterior nasal aperture. যেটা আমরা বাইরে থেকে দেখছি, this is anterior nasal aperture. এটা গিয়ে কোথায় ওপেন করছে? This is the posterior nasal aperture. The nose কিন্তু একটা নেই, ঠিক আছে? Anterior nares, posterior nares. Okay, bilateral আছে। আর মাঝখানে কি আছে? Nasal septum. So nasal septum is always deviated. It is not straight. Remember this one. Okay, সবাইকারই কিন্তু একটুখানি সেটা ইয়ে থাকবে, bilateral থাকবে। Okay, so it is known as DNS. There is one thing that is known as DNS. DNS কাকে বলে? Deviated nasal septum. যদি ধর একটা দিকে nasal septumটা সরে যায়, কি হবে সেক্ষেত্রে? Respiration problem হবে। আর কি প্রবলেম হতে পারে? Do you know snoring? Snoring. Okay, so it is also known as obstructive sleep apnea. তাই না? এটা পড়েছিস তো, obstructive sleep apnea. So if you go this side, so first foramen what you will get, see over here, প্রথম foramen কি পাবি? That is the foramen oval. Okay, first foramen you will see that is known as foramen oval. Okay, so which one is the foramen oval over here? So যেটা সবথেকে laterally আছে, this is the foramen oval. Okay, then most laterally you will get another foramen, so that is known as foramen spinosum. See the picture, you could see the foramen oval. Foramen ovalটা দেখতে পাচ্ছেন সবাই? So which thing will pass? Abbreviation কি হবে? MEL. Okay, প্রথমে কি হবে? Write it down. The structure, ভীষণ important এটা। Okay, structure passing through the foramen oval. Yeah, it is correct. Foramen oval আছে, কিন্তু we are এখন পুরো region wise, anatomy is regional anatomy. Okay, so foramen oval দিয়ে কি কি পাস করে? mandibular nerve, accessory meningeal artery, okay, lesser petrosal nerve, and E for emissary vein. E for emissary vein, ভীষণ important এটা। Okay, the structure passing through the foramen oval. Okay, so next one you are having the foramen spinosum. Foramen spinosum দিয়ে কি যায়? Write it down. It is the Vidian nerve. Median nerve নয় কিন্তু Vidian nerve. VIDIAN. Foramen spinosum. See over the picture. You see the foramen oval. আমার কাছে তো হ্যাঁ না foramen ovalটা দেখ foramen ovalটা medial আছে তার সাইডে যেটা আছে small one you see that side okay laterally you could see one minute foramen so this is the foramen spinosum এটা দিয়ে কি যায় Vidian nerve so what is Vidian nerve so write it down Vidian nerve is made by greater petrosal and deep petrosal okay Vidian nerve টা একটু পড়ে নিবি okay Vidian nerve greater and deep petrosal nerve greater and deep petrosal nerve okay so then if you are seeing one fossa over here this is the zygomatic arch so below the zygomatic arch there is one fossa you could see there is one small fossa so that is also known as mandibular fossa এখানে কি অ্যাটাচ থাকে বলতে পারবি name signifies mandibular fossa definitely some part of mandible which part have you seen the bone mandible it is not over here if you see the mandible superiorly it has got two elevated part okay একটা হচ্ছে তোর coronoid process another one is condyle of mandible condyle of mandible which will form temporomandibular joint so that will join to the mandibular fossa understood there is one joint temporomandibular joint have you studied temporomandibular joint so if you see this part this is which part this part is from which bone that is the temporal bone so that is the mandibular fossa just remember the mandibular bone would be attached over here write it down mandibular fossa the condyle of mandible will be attached over here okay so now you are going most posteriorly eta hoye gelo mandibular fossa see everyone this is the mandibular fossa now if you are going more posteriorly you are getting one meatus so that is known as external acoustic meatus okay so write it down posterior to it is the external acoustic meatus okay now immediately about the external acoustic meatus you are having mastoid process posterior to the external acoustic meatus see the picture that is the mastoid process okay so this one is the foramen oval foramen spinosum okay next if you go to the middle cranial fossa what are the other thing you will get how many foramen আর কি foramen আছে দেখ তিনটে foramen পাবি okay middle cranial fossa তে তিনটে foramen পাবি so don't confuse between this structure and this structure okay because this is the half skull there is one thing when you are taking only the base okay ওখানে কিন্তু আমি পাবো কি আমি যেটা তোকে বলছি সরি this structure and this structure okay so if you see over here এখানে দেখ আরো বেশি foramen পাবি এইটার মধ্যে so this is the intracranial fossa যার মধ্যে ব্রেনটা আছে বোঝা গেছে এখানে যদি তুই দেখিস এখানে যতগুলো foramen পাবি কি পাবি foramen oval পাবি আর কি পাবি foramen rotundum পাবি ওকে foramen rotundumটা কিন্তু এটাতে পাবি okay optic canal পাবি sella tarsica পাবি everything you will get so that is known as intracranial fossa kintu this is the base of skull what I am saying only 3 foramen you will get over there write it down these 3 foramen are number 1 is foramen oval then next one is foramen spinosum okay and the third one is foramen lacerum third one Okay, now if you see the foramen lacerum, where it is situated, see this is somewhat very much irregular. So that's why it is somewhat lacerated, right? So that's why the name came lacerum. Okay, which structure passes? Just write it down, emissary veins. Emissary vein used to pass over there. Okay. Then we are coming most posteriorly. So if you see most posteriorly, what are the thing you could find? There are numerous other foramen. Okay, so what are they? First one is the, write it down. So tell me which structure would be passing? Carotid canal, internal carotid artery, আর কেউ যাবে? jugular vein তো jugular foramen দিয়ে যাবে। Carotid. So do you know the cranial nerve, how does it passes? First one is, প্রথম cranial nerve টা কি? Olfactory. So olfactory would be passing, write it down, I am telling you one formula. So first one is olfactory will pass through the cribriform plate of ethmoid. Second টা কি? Optic. So optic will pass through the optic canal. Third one is oculomotor. So where it pass? Oculomotor কাকে সাপ্লাই করবে রে? চোখের মাসল গুলোকে। So where it will come? Write it down, superior orbital fissure. Okay, fourth one is again superior orbital fissure. Okay, fifth one is trigeminal. So it will come through the foramen rotundum. Okay, এটাতে নেই, foramen of rotundum. Okay, intracranial fossa. তারপরে 6 নার্ভটা কোথায় যাবে? আবার superior orbital fissure. 6 নার্ভ যাবে through the superior orbital fissure. 6 নার্ভ কাকে সাপ্লাই করে? আর ট্রক্লিয়ার নার্ভ কাকে সাপ্লাই করে? ট্রক্লিয়া আবার কি? How many orbital muscles are there? Tell me. 6 muscles are there. Which are they? চারটে rectus, eyeball muscle. চারটে rectus আর দুটো oblique. Okay, so write it down. Trochlear nerve will supply trochlear nerve will supply the superior rectus. Okay, and abducens nerve will supply the lateral rectus. Okay, so what about the trigeminal nerve? Remember, this is the most thickest nerve. Okay, so where does it supply? It has got 3 division. কিরকম? একটা দেবে তোর eye, so that is known as ophthalmic. Another one is going to the maxilla, so that is the maxillary. Another one is the mandibular. বোঝা গেল? তিনটে nerve. Then the next one is 7th and 8th. So where does it pass? 7th nerve টা কি রে? Facial. আর 8th কে বললো? Glossopharyngeal. 8th টা কে? Auditory or vestibulocochlear. So where does it pass? দুটোই যাবে through the internal acoustic meatus. Write it down. Internal acoustic meatus. 7 and 8. Now coming to the 9, 10, 11. 9, 10, 11 will pass through the jugular foramen. Once you remember this, the whole base of the skull is over. Okay. So 9, 10, 11 is jugular foramen along with the internal jugular vein. Write it down. Along with the internal jugular vein. So what about the last one? Hypoglossal. কোথা দিয়ে যাবে? না, hypoglossal কোথা দিয়ে যাবে? So there is one specific canal that is known as hypoglossal canal. Where it's situated? So if you see the foramen magnum, see over here, if you see the foramen magnum, this is the condyle. of the atlas where it merged. So just below that you will find one canal. So that is known as hypoglossal canal. So that is na eta condylar fossa niche I could not able to show you. It is found on the interior aspect. Okay, interior aspect ekta foramen pabe. So that is known as hypoglossal canal. Busali. So this is the 12 nerve. So why I am saying the carotid canal? Which nerve will go then over there? Facial nerve. Facial nerve কি করে intracranial ইয়ে থেকে ফসা থেকে বেরিয়ে আসে? Okay, by this carotid canal. বোঝা গেল? So now see, if you see the blue line is the anterior cranial fossa, middle one is the middle cranial fossa, and the last one total occipital bone is the posterior cranial fossa. Okay. So these are the three demarcation. Now first one is this thing already I have told. Okay. The palatine glands and the different structure. Okay, so now write it down, middle part of the base of the skull or the middle cranial fossa. First one is the posterior border of vomer, ala of the vomer, which attached with the rostrum of the sphenoid. Rostrum of the sphenoid. Okay. Then next is vomerovaginal canal. So this is the which is situated just beside the vomer. Okay, so that is one canal. So rather than that, you are having medial pterygoid plate which transmit the pharyngeal nerve and pharyngeal vessels. এগুলো একটু লিখে রাখ, এমসিকিউ আসতে পারে। ওকে, ওকে। Now coming to the pterygoid process. Okay, so pterygoid process is from the scaphoid fossa to the spine of the sphenoid. From the scaphoid fossa to the spine of sphenoid, 5 foramen could be appreciated. Okay, first one is foramen ovale, right? This structure you have written. Then next one is foramen spinosum, that is middle meningeal artery and also the nervus spinosus. Okay. Then the foramen vessalis, write it down, foramen vessalis. আরেকটা foramen থাকে, that is known as foramen vessalis. Between the scaphoid fossa and the foramen ovale. And this foramen vessalis is too much important because it is connecting to the intracranial venous sinus with the cavernous sinus. So where the cavernous sinus is situated? It is situated just posterior to the face. Okay, so any type of facial infection could go to the cavernous sinus, and from cavernous sinus where it will go to the pterygoid venous plexus. Okay, and see the fourth one is foramen innominatum. Write it down. Foramen innominatum. Foramen innominatum is foramen ovale and the spinosum. Foramen ovale and the spinosum. That means you have to tell these two foramen. একটা হচ্ছে foramen vessalis and foramen innominatum. Please write it down, these two. Foramen vessalis and foramen innominatum. Now coming to the posterior part or the base of the skull. Okay, so we are having the foramen magnum and another one is external occipital protuberance and external occipital crest. So where you will get the crest? Where is the crest? This is the. So for that you have to see the inner aspect. ঠিক আছে, এইটা হচ্ছে তো crest. Okay, see this one, both side it is going. বোঝা গেল? So that is the crest. Okay. Now coming to the lateral area. So posterior fossa is very easy. Lateral area তে প্রথমেই কি পাবি? That is the occipital condyle. দেখ এই দুটো condyle কে কি বলছি আমি? Occipital condyle. Why? It will articulate with the condyle of atlas. Atlas is taking the whole weight. Okay. So then next one is the condylar fossa. Next one is the condylar fossa. Then is the hypoglossal canal on the inner aspect. Okay. Write it down, this all. Then the jugular foramen. The jugular foramen. 3 hours you have to write. Make the practice. Jugular foramen, squamous part of occipital bone, styloid process কোনটা জানিস? This one. I told you yesterday from the temporal bone, one elongated process are coming, so that is known as very small one, this one. So that is the styloid process. Then the mastoid process, you know this one, mastoid process. Then stylomastoid foramen, this foramen is very much important. Stylomastoid foramen, কেন? The facial nerve used to emerge from the stylomastoid foramen along with the stylomastoid artery. এটা কিন্তু কোয়েশ্চেন আসতে পারে, what are the content of stylomastoid foramen? Write it down. Which is the content of stylomastoid foramen? The facial nerve and stylomastoid artery. Okay. এখানে কি stylomastoid foramen টা দেখা যাচ্ছে? Yeah, see over there, stylomastoid foramen. Okay, stylomastoid means, see, this is the styloid process, this is the mastoid process, so in between one foramen is there. Okay, so that is the stylomastoid foramen. Okay, and then see, it is more proximal over here, so you could find the posterior cranial fossa কি পাবি? jugular foramen. See the jugular foramen, it would be little bit large. ওকে, কেন? কারণ তিনটে ক্রেনিয়াল নার্ভ যাবে আর একটা হচ্ছে তোর জুগুলার ভেন যাবে, ইন্টারনাল জুগুলার ভেন যাবে। ওকে, সো দ্যাটস ওয়াই ইট ইজ লিটল বিট লার্জ। ওকে, and see, just proximal to the jugular foramen is the carotid canal, just proximal to it. Okay, so if you see the posterior, tell me the foramen গুলো কি কি আছে বল? মিডিয়ালি যেটা আছে সেটা কি? মিডিয়ালি যেটা আছে foramen lacerum. So if you go that side, lateral side, foramen oval, তার সাথে কি থাকবে? foramen spinosum, আর আরো দুটো foramen বললো, একটা কি foramen innominatum আর foramen vessalis. Okay, so total 5 foramen you have to remember. So see here, they have labeled this one, so everything is clear. First one is the foramen cecum. Okay, so which one is the crista galli? This one is the crista galli. Okay, it is found in the frontal bone, and it is also looking like a, it would be pierced by the olfactory nerve. কতগুলো olfactory nerve আছে? MCQ আসতে পারে। কতগুলো জানিস? Number of olfactory nerve, কাছাকাছি গিয়েছিস। কত থেকে কতগুলো olfactory nerve? olfactory nerve কে একটা থাকে না অনেকগুলো থাকে? মাল্টিপল থাকে, because it is taking the sensation olfaction. Okay, and there is the posterior aspect of, or the superior aspect of this each nerve, there is one bulb that is known as olfactory bulb. Okay, so where it will emerge? It will emerge from this cribriform plate. See over there, cribriform plate কোন bone পাবে? frontal bone. Okay, frontal bone পাবে। Then next one is the, so this is the first nerve, cribriform plate এ কি থাকবে? first nerve or the olfactory nerve. Then second one would be coming to the optic canal. So what is the situation of optic canal? Optic canal means which is taking the vision, right? It is going to the eyeball. কিরম থাকে optic nerve টা? Have you read about optic chiasma? কেন? cross করে, তাই তো? and in between which gland is there? pituitary. Okay, pituitary কোথা থেকে? sella tarsica sphenoid. Okay, yeah, so now see one thing that is known as superior orbital fissure. So which one is the superior orbital fissure? I will tell you the norma frontalis. So superior orbital fissure, see the above of the orbital cavity, which bone is there? I told you lesser wing of sphenoid. Okay, and below is the greater wing of sphenoid. তাহলে superior orbital fissure মানে কি? Fissure means it is elongated foramen. Okay, so many structure is passing. So above কে থাকবে lesser wing of sphenoid, below থাকবে greater wing of sphenoid. Okay, so superior orbital fissure দিয়ে কি কি যাবে? কতগুলো নার্ভ বলেছি বল? Already I told. কতগুলো নার্ভ যাবে? তিনটে নার্ভ যাবে, তিনটে ক্রেনিয়াল নার্ভ যাবে। নাম্বার 1 ইজ অকুলোমোটর, তাই তো, তারপরে যাচ্ছে ট্রক্লিয়ার, তারপরে যাচ্ছে তোর অ্যাবডুসেন। 3 4 6 এই তিনটেই কাকে সাপ্লাই করছে? আই কে। ওকে, ইট ইজ সাপ্লাইং দ্য মাসেল অফ আইবল। ওকে, সুপিরিয়র অরবিটাল ফিশার হয়ে গেল। তারপরে দেখ ফোরামেন রোটান্নাম। ওকে, ফোরামেন রোটান্নাম দিয়ে কি পাস করবে বললাম? ট্রাইজেমিনাল নার্ভ পাস করবে, and it has got 3 division: ophthalmic, maxillary, mandibular. Okay, then the next foramen is ophthalmic, maxillary and mandibular. তার মানে এটা হবে তোর V1 5 তো 5, so V1 V2 V3, V1 V2 V3. Okay, so if you see the foramen rotundum come backwards, so first foramen you will get, so that is known as foramen lacerum. Now you will go lateral side, so you will get the foramen ovale and foramen arekta ki spinosum. So foramen spinosum would be very proximal to the foramen ovale, ekdom beside e thakbe laterally, sob theke laterally thakbe. Tarpore ki ache, then coming to the internal acoustic meatus, এইটার কথাই বলছিলাম। ইন্টারনাল অ্যাকস্টিক মিউটাস দিয়ে কি কি যাবে? কোন কোন নার্ভ? এই মাত্র বললাম 7 and 8, বোঝা গেল? ফেসিয়ালও যাবে, আবার তোর অডিটরিও যাবে। এবার দেখ ফেসিয়াল নার্ভটা কি করবে? ফেসিয়াল নার্ভ কাকে সাপ্লাই করে বল? রাদার দ্যান ফেস, ইট উইল সাপ্লাই এনিথিং এলস? টাং পড়ানো হয়েছে? So see the taste sensation. Taste sensation of anterior 2/3 of tongue has been taken out by chorda tympani, which is coming from the facial nerve. Understood? So that's why it is running through the internal acoustic meatus. ঠিক আছে, সেই জন্য সেটাকে chorda tympani, একটা ফেসিয়াল নার্ভের নাম কেন হবে chorda tympani? বোঝা গেল? তো ওটা ওখান থেকে নিচ্ছে, ঠিক আছে? Then coming to the hypoglossal canal. So if you see the foramen magnum, I told where the condyle is situated, just interior to that you are having the hypoglossal canal. কে যাবে এর মধ্যে দিয়ে? শুধুমাত্র hypoglossal nerve। কাকে সাপ্লাই করবে? the entire muscle of tongue, ঠিক আছে? যতগুলো entire muscle of tongue is supplied by hypoglossal. Now clinical anatomy, write it down. Clinical anatomy, number 1 is linear fracture. Linear fracture হতে পারে a forceful hit on the forehead causes linear fracture of both vertex and the base. ভার্টেক্স মানে কি কি বলেছিলাম? দিস ইজ দ্য ভার্টেক্স, তাই তো। আর বেস মানে কি? ইফ ইউ কাট দ্য স্কাল, সো সি দিস ইজ দ্য বেস, সো ইট উইল ইনজিওর বোথ দ্য ভার্টেক্স এন্ড বেস। ওকে, দেন নেক্সট ওয়ান ইজ কনভার্জেন্স অফ ফ্র্যাকচার। দেখ সি, ইফ দ্য ফ্র্যাকচার উইল হ্যাপেন, হোয়ার দ্য ফ্র্যাকচার লাইন উইল গো, কোন দিকে যাবে? যেখানে ফোরামেন আছে, তাই তো। ফোরামেন কি কি আছে? ফোরামেন ম্যাগনাম আছে, আর অ্যান্টিরিয়ালি কি ফোরামেন আছে? সিলা টার্সিকা আছে, তাই তো। তো ফ্র্যাকচার লাইনটা কোথায় যাবে? সিলা টার্সিকা অথবা ফোরামেন ম্যাগনামের দিকে। ওকে, দেন দ্য নেক্সট ওয়ান ইজ ডিউ টু প্রেজেন্স অফ ন্যাচারাল থিক বোনি বাট্রেস অ্যাট দ্য বেস অফ দি স্কাল। কেন? বিকজ ইউ আর গেটিং ওয়ান ভেরি থিক লেয়ার অফ বোন অন দ্য বেস অফ দি স্কাল। ওকে, এক্সেপ্ট দিস রিজিয়ন। ওকে, then the next one is in case of basal fracture, base of skull fracture হতে পারে? RTA, ঠিক আছে, রোড ট্রাফিক অ্যাক্সিডেন্টে হতে পারে base of the skull is get fractured. Okay, so in that case what will happen? Laceration of structure passing through may complicate the tissue like the foramen of lacerum. Foramen lacerum দিয়ে কি কোন স্ট্রাকচার কাটবে? that is the internal carotid artery, ঠিক আছে। সো দ্যাট ইজ দ্য কজ অফ ডেথ, বোঝা গেল? দ্যাট ইজ দ্য কজ অফ ডেথ। নাও কামিং টু, if the fissure line involves the groove having meningeal vessels and dural sinus, then the epidural hematoma might result. Epidural এপিডুরাল মানে অ্যাবাভ দ্য ডুরা ম্যাটার, মানে স্ক্যাল্পের লেয়ারটার নিচে, ঠিক আছে, স্ক্যাল্পের লেয়ার তিনটে, হ্যাঁ মেনিনজিসের তিনটে লেয়ার থাকে, ডুরা ম্যাটারে কটা লেয়ার থাকে, দুটো লেয়ার থাকে, ঠিক আছে। So then next one is fracture of the base of the skull often forms zigzag pattern to avoid thickening, and these lines having raised. Just remember that there will be zigzag pattern. Okay. আচ্ছা, যদি ট্রানজিশনাল সেল কার্সিনোমা হয়ে থাকে, ট্রানজিশনাল সেল কার্সিনোমা কোথা থেকে হবে? মিউকোসা অফ দ্য পিএনএস। হোয়াট ইজ পিএনএস? peripheral nervous system, paranasal sinus, paranasal sinus. So what do you mean by paranasal sinus? Have you heard some patient is having pain for sinusitis? So what are the sinus? Sinus, what is the function of sinus? Paranasal sinus, তাই তো? So these are the air filled cavity. নিউম্যাটিক বোন, এক্সাম্পল অফ নিউম্যাটিক বোন স্যার কি কি বোন আছে? নিউম্যাটিক বোন মানে এয়ারফিল্ড বোন। স্টার্নাম is an example of flat bone. You need the head to be lighter in weight. For that there are some pneumatic bone. Which are they? ম্যাক্সিলা, ম্যাক্সিলারি অ্যাসাইনাস। ওকে, ম্যাক্সিলা আছে, আর কে আছে? স্পেনোয়েড আছে। ওকে, আর কে আছে? ফ্রন্টাল আছে। আনাদার ওয়ান ইজ এথময়েড। সো দিজ আর অল নিউম্যাটিক বোন এন্ড হিয়ার ইজ দ্য প্রেজেন্স অফ প্যারানেজাল এয়ার সাইনাসেস। ঠিক আছে, so I'm just keeping this one. So it may erode the skull base. Okay, any kind of tumor may erode the skull base. Malignant tumor, যদি ধর ম্যালিগন্যান্ট টিউমার হবে, what you will perform, you will do one PET scan, তাই তো? by that way you could see the metastasis has been happened to the brain, okay, to the skull. Okay, এটা কিন্তু খুব ইম্পর্টেন্ট, প্লিজ রাইট ইট ডাউন। there are two things, one is rhinorrhea and another one is otorrhea. So both are CSF rhinorrhea, CSF otorrhea. কখন হবে? when there is a fracture of the base of the skull. Okay, if somebody fallen from the height, for that reason also, or any kind of RTA, if you are seeing some fluid is coming from the nose or from the ear, so the case is very much complicated. Okay, because একদম লাস্ট স্টেজে পৌঁছে গেছে, বোঝা গেছে? CSF already coming out. So otorrhea and rhinorrhea, বুঝা গেল? আরেকটা কি? facial paralysis due to damage of 7th cranial nerve. So that is the Bell's palsy. Okay, loss of hearing হলে কোন নার্ভ ইনভলভ? অডিটরি। Okay, vertigo, nystagmus, do you know? Are you aware of this term? Vertigo মানে হচ্ছে মাথা ঘোরা, but there are two type of vertigo. When the person is fixed but environment is rotating. Okay, আবার কখনো এমন হতে পারে নিজে ঘুরছে, person is rotating, environment is fixed. Okay, so there are two type of vertigo. Okay, another one is nystagmus. What is nystagmus? These are the horizontal movement of eyeball, just like pendulum of clock. Okay, puro horizontal, this is a kind of disorder. Okay, so that is also occurring due to this nystagmus. Okay, so damage to the 8th cranial nerve. 8th cranial nerve টা কোথায় থাকে? কালকে আমি বলেছি ইনার এয়ার কোথায় থাকে? পেট্রাস পার্ট অফ টেম্পোরাল বোন, তাই তো? তাহলে পেট্রাস পার্টে যদি ড্যামেজ হয় কোন নার্ভ যাবে? 8th। কোনটা যাবে? ককলিয়ারটা যাবে, বিকজ দিস আর অল ফর ব্যালেন্স। কেন হরিজন্টাল মুভমেন্ট অফ আইবল হচ্ছে, কেন ভার্টিগো হচ্ছে, বোঝা গেছে? সব ডিউ টু the balance. Okay, then the last one, write it down. Last one is discoloration and edema of mastoid process. অনেক সময় দেখা যায় this mastoid process, see the mastoid process of the patient, so you see the discoloration. Okay, black color. So why it is? Due to the involvement of sigmoid sinus. Due to the involvement of sigmoid sinus. Okay. So see, this is a one kind of thing. Okay, this thing will happen if the base of the skull has been injured. Okay, প্রথমে আইজ এর কি হবে? রেকুন আইজ, ব্ল্যাক আই, ব্ল্যাক আই আর রেকুন আইজ, আর কি হবে? CSF otoria, CSF rhinoria. Okay, so you could see the base of the skull is injured. Okay, so that is about the base of the skull. Okay, so I will also tell, just take a small break, I will take the norma frontalis. Okay, how many bones you could see from anterior aspect? Write it down. First one is frontal, number 1 is frontal, then what is this? Then coming the nose. So now tell me the orbital cavity, how many bones you know? It has got 4 wall, তাই তো? এটা হচ্ছে superior wall, inferior wall, medial wall, lateral wall. How many bones? প্রথমে তুই inferior wallটা বল। inferior wall-এ কি থাকবে? zygomatic, another one is maxilla. superior wall-এ কি থাকবে? frontal আর zygomatic. laterally কে থাকবে? zygomatic. So see, if you are talking about norma frontalis, so what are the bones it is taking part? Frontal, then this side is the zygomatic, maxilla. Okay, what are the 9 nasal bone I told? First one, what you could see the bridge, right? Up to here, this is whole the cartilage. Okay, only here is the bone, so that is the nasal bone. What are the other nasal bone? আর কি nasal bone আছে? lacrimal, then inferior nasal concha 2, and another one is the 2 palatine and 1 vomer. So all would be found on the orbital cavity. And what is this? This is the maxilla. Okay, and this side is the zygomatic. So at first, see, we will come one by one region. Okay, frontal region, what are the thing you have to study? Write it down. Frontal region. So frontal region is just above the orbital cavity. Okay, so if you see the above the orbital cavity, what are the thing you could see? First one is the superior ciliary arch, this one. Okay, where the eyebrows are situated. So that is known as superciliary arch or superior ciliary arch. Okay, then see at the middle there is one space that is also known as glabella. Between the 2 superciliary arch, so there is one space that is known as glabella. Okay, here is the glabella. Then if you are coming downwards, you could find here is one space where the root of nose starts, that is known as nasion. Okay, write it down. The nasion is found above the 2 nasal bone or the superior aspect of 2 nasal bone. Okay. Okay, what are the other thing you have to see over here? There is one notch. If you see the superior aspect of orbital cavity, there is one notch. So this is also known as supraorbital notch. Supraorbital notch. Okay. Then the next one is, this supraorbital notch is converted into supraorbital foramen. Write it down. This supraorbital notch is converted into supraorbital foramen. Okay, now what are the things are present over here? Have you studied the facial muscle? Not yet. So here are the attachment of some facial muscle, right? Superciliary arch, where you have written, write it down, corrugator supercilii. Corrugator supercilii. Okay, corrugator supercilii. Glabella te ke thake? Procerus. Okay, then at the nasal, nasion কি থাকবে? nasalis. nasion থাকবে nasalis. Now the question is, there is one formation of one foramen that is known as supraorbital foramen. So which things are present over there? Write it down. Supraorbital nerve and vessels. Supraorbital nerve and vessels. So supraorbital nerve is coming from which nerve? It is coming from mandibular nerve. Write it down. It is coming from the ophthalmic division of mandibular nerve. Okay. So these are the things you have to see on the frontal region. Now I am coming to the orbital cavity. Okay. So what is the boundary of orbital cavity? They could ask. Okay. So at first write it down, inferior boundary. Inferior boundary. So you have to tell the name. Okay. So what is the name? You have to say orbital plate of maxilla. Orbital plate of maxilla and orbital process of zygomatic. Now see, this arch is zygomatic arch and this is the two bone that are making union. This is the frontal bone, this is the zygomatic bone. So this is known as frontozygomatic arch. How does it will form? Frontozygomatic arch. Eta ki bone bol? Frontal bone. So zygomatic process of frontal and this is the frontal process of zygomatic. So that will form the frontozygomatic arch. Okay, so write it down. The zygomatic process of frontal, the zygomatic process of frontal bone and the frontal process of zygomatic bone. It will form the frontozygomatic arch on the lateral boundary of the orbit. Okay. Now coming to the superior boundary. So if you see the superior boundary, what are the bone you will get? Opore ki ache? Kon bone ache bol? Only one bone. So that is the frontal. Okay. So you could see over here that frontal. Okay. So this is also known as orbital plate of frontal. Write it down. This is the orbital plate of frontal. Superior boundary. Okay. Now coming to the medial boundary, which is very much important. So many bones will come. Okay. Medial boundary ki ki thakte pare bolte parbi? Medial boundary of orbital cavity. If you see over here, first bone is lacrimal. Okay, first bone is lacrimal. Then the next one is frontal process of maxilla. Frontal process of maxilla. And another one is maxillary process of frontal. So you could find, দেখতে পাচ্ছিস কোনটা maxillary process of frontal? This one. Okay. This is the maxillary process of frontal and along with lacrimal. Okay, lacrimal and palatine, it will form the medial boundary of orbital cavity. Medial boundary of orbital cavity. Now, in the orbital cavity, there are two fissures. One is supraorbital fissure, another one is infraorbital fissure. You could find there are two trigone is going. Okay, so supraorbital fissure, already I told you how does it form. Write it down. Supraorbital fissure is formed by superiorly ke thakbe lesser wing of sphenoid and inferiorly greater wing of sphenoid. Okay. Now, which of the structure? This may comes as short note or long question. Very much important. Structure passing through the superior orbital fissure. Structure passing through the superior orbital fissure. Already I told you. কি কি থাকবে বল? কোন কোন cranial nerve? Oculomotor 3, 4, 6. 3, 4, 6. So that means oculomotor, branches of oculomotor. Now this oculomotor nerve has got two division, anterior division and the posterior division. Okay. So two division of oculomotor nerve along with trochlear nerve and another one is abducens nerve. So next one is, so tell me the nerve supply of oculomotor. কতগুলো আইবলের মাসল বললাম? 6. তো সুপিরিয়র অবলিক কে সাপ্লাই করবে? ট্রক্লিয়ার নার্ভ। ল্যাটারাল রেকটাস কে করবে? অ্যাবডুসেন নার্ভ। আর কি কি মাসল তাহলে বাকি রইল? রিমেনিং অল, তাই তো? তার মানে একটা হবে তোর মিডিয়াল রেকটাস, সুপিরিয়র রেকটাস, ইনফিরিয়র রেকটাস। ওকে, আরেকটা ল্যাটেরালটাকে করবে অ্যাবডুসেন্ট। বুঝতে পারলি? তাহলে কতগুলো মাসেল বাদ রইলো? আর চারটে কি কি বাদ আছে? একটা হচ্ছে তোর ইনফিরিয়ার অবলিক, আর তিনটে রেকটাস, মিডিয়াল, সুপিরিয়ার, ইনফিরিয়ার। ঠিক আছে, এগুলোকে কে সাপ্লাই করবে? oculomotor. These muscle would be supplied by oculomotor along with one muscle which is closing the eyelids, that is known as LPS, that is levator palpebrae superioris. Levator palpebrae superioris একে কে সাপ্লাই করবে? oculomotor nerve. Okay, and 4 and 6 already I told. 4 is superior oblique and lateral rectus is the abducent. Okay, along with that, first one is, write it down, lacrimal nerve. Lacrimal nerve, ভীষণ important এটা। Okay, then next one is frontal nerve. Nasociliary nerve, nasociliary nerve. Okay, and the ophthalmic artery, ophthalmic artery and vein, ophthalmic artery and vein. This is passing through the superior oblique fissure. Okay, then next one is, write it down, inferior orbital fissure, inferior orbital fissure. Which thing will orbital? This one, it is present on the eyeball. Okay, inferior orbital fissure. So structure which is passing through is, first one is maxillary nerve, along with zygomatic branch, maxillary nerve along with zygomatic branch, infraorbital artery, infraorbital artery. Okay, and another one is nasopalatine nerve, nasopalatine nerve. Don't confuse between fissure and the foramen. Fissure mane ki? This is the elongated. See, supraorbital foramen is this one, fissure is this one, infraorbital foramen is this one. Okay, this is the infraorbital foramen, write it down. Infraorbital foramen is found on the superior aspect of maxilla, on the superior aspect of maxilla, and which thing is passing over here? Infraorbital nerve and vessels, infraorbital nerve and vessels. Okay, and what is this? This is known as anterior nasal spine, this one. Okay, and this is the Nasian. If you see the nasal cavity, two structure, one is anterior nasal spine, this is the Nasian. Okay, and which are the bone that you know? Which are the bone that will form the nasal cavity? All the nasal bone you have to say. This is only nasalis. The remaining all bone are found over here. Okay, inferior nasal concha, palatine. Okay, lacrimal চলে গেছে, lacrimal already ভোমার থাকবে। Okay, so these are the bones found over the cavity. আর এখানে কি পাবে? This is what? This is the incisive fossa, incisive tooth এর উপরে এটা আছে, and this is the canine fossa, and this is the alveolar arch. Okay, so this thing you have to remember for the norma frontalis. Okay, and this is the zygomatic arch. Understood? So this is all about the norma frontalis. বোঝা গেল? Thank you.